Should I start, ma'am?
Good morning, everyone, and welcome to this session. So we have to have some changes, but first topic is which the director? I don't have the program. Have you got the program? Has anyone got the program? You have got the program set? It's session 4. This one is the only, no? Okay. The past session is you're Dr. Muralidhar, no?
No, ma'am.
No.
Dr. Aarti is not here.
Achha,
So
he
Dr.
is
Karan
going to
speaking
present.
in-
Okay, Dr. Karan. Okay, Dr. Karan is going to present on behalf of Dr. Aarti Hedda, and she will be present on the key points in the M6. Okay, please start and keep to the time.
Yes, ma'am. So, small incision cataract surgery, the key points. So, first comes the choice of anesthesia. You should choose what works best for you. If you're a resident or a fellow who's just started training, peribulbar anesthesia is good to go. Apart from that, then you can shift to subtenons. A lot of institutes such as Arvind have now shifted completely to subtenons anesthesia. There are people who have done subconjunctival, and there are people also doing topical. But you choose what works best for you. The pre-op workup is extremely important. From the refraction, keratometry, biometry, the anterior and the posterior segment evaluation, and the grading of cataract. Some people do an OCT as well, sometimes or in all their cases. The superior rectus brittle suture is extremely important, particularly in the initial stages, and it gives the globe stability. And I would recommend that you do it under the microscope. You have a better stabilization of it, better visualization of it, and it really helps. So first let it pass completely and then go ahead. The next step is the conjunctival flap. A good dissection is extremely important. You should not have any tenons for it, and you cauterize only as much as required only. Don't do any extra cautery, and try to leave a frill of preserved limbal stem cells because it's good, and you try to prevent buttonholing here. The incision, we all know about the Cox funnel, so it's for an astigmatic neutral thing. The various incisions are there. You have the straight incision, the frown, the chevron, and the smiling incision is what you would not recommend. The ideal incision is located about 1 to 2 millimeters from the anterior border of the limbus, and the depth should be about 1/3 to half thickness of the sclera. The crescent should be about translucent there, and it's about 1 to 2 millimeters or 2 millimeters in the internal corneal lip should be there. When you're going to this, after you need to do a tenotomy as well, or you can scrape it with the blade, 15 number blade, and then do the incision. It takes out any extra tenons that are there. Initially, when you're starting, go for a larger incision and start with a straight one. This is something initially you can graze the incision and then you can go inside. A couple of modifications is such as you can go for a no conjunctival flap one, as you can see in the video over here. It helps to preserve the limbal stem cells. There's less fibrosis over here. Advantages, you're leaving a comparatively virgin conjunctiva over here. It's fairly easy with experience. Beginners, the problem that happens is with the depth perception. The grip and the tunnel, now you can hold it at, I prefer to hold it at the opposite side, that is at 6 o'clock. You can hold it anywhere, or you can give a groove, create a groove as the first video shows over here, and then go inside, wriggly motion, then movements on the side, and then you can create the tunnel. Using a keratome, preferably you would prefer a beveled down keratome, but it's not always available. So then this is a beveled up one, and then you can go inside, dip inside and enter, and then forward movements is what you would prefer to open up the rest of the incision. The indications of a temporal section would be if there's high against the rule astigmatism, or if there's a presence of a superior filtering bulb. It induces less astigmatism in comparison to the superior incision. There's no brow effect, easier in deeper orbits, and gives a good red glow as well. Disadvantage would be the orientation for the surgeon. Regarding the incision, always use sharp instruments, calculate your SIA, and if possible, do it along the steep axis. The incision size depends on the magnitude of astigmatism and also the grade of the nucleus. So you have to customize accordingly. The side port preferably should be 90 degrees away, and again use sharp instruments. Otherwise, there's always a risk of DMD. Coming to the rexus, you use the shearing forces or the ripping forces. You can do it with the cystitome, or you can do with the utrata forceps as well. It's extremely important to maintain a deep anterior chamber while you're doing SICS and in the rexus also. So otherwise, the prevention to the periphery can be prevented. Again, what I would stress over here, it should be outside to inside and not inside to outside. Whenever in hard cataracts or you've got brown cataracts or a mature cataract, it's always advised to do a trypan blue. If you're resident or something, finding it difficult, then you can always do a can openers. In such cases, small rexus, if you have, you can give relaxing cuts. So, yeah, so this is how you can do it through the side port, or you can even do it through the main tunnel. Whatever suits you, it's okay. But remember, when you're doing through the main tunnel, it should be pressed on the upper lip. That's when the chamber will not collapse. In cases of hypermature cataracts, Morgagnonian cataracts, because they have very weak zonules, something like an envelope technique can be done, a modified one where you incise it with a keratome, and then you can give 2 cuts with a Varnas scissor, and then once you have you can see the calcific zones that are there, and do a proper rexus would sometimes be difficult in such cases because of the weak zonules, and then you can complete the rexus and the rest of the case as well. Utrata really helps over here. So I would recommend a change order. I do a superior rectus brittle suture followed by a side port, then a rexus, and then a tunnel. The reason is, this is particularly helpful for residents and beginning surgeons. The reason being that if you make the tunnel first and if you have a premature entry, what will happen is the iris comes out, the pupil constricts, and it becomes really, really difficult for you to do the rest of the surgery, and the senior has to take over. But if you do the rexus first, the half of the surgery, the main part of the surgery is done. Everything becomes easy. Rest, you don't need that much of a big nucleus. A good, very important thing is to do cortical cleaving hydrodissection. You will see the waves over here in this video. Now you see it, the waves. So you can do here, then tap in the center, and then again do it to the other side, and you can even do a hydroprolapse if your nucleus is if your rexus is big enough. So this is what a hydroprolapse looks like. So I'm gone over here, and then using the same instrument, you can actually rotate it and bring it out into the anterior chamber. It's fairly easy, not that difficult. In cases where it becomes a little bit difficult sometimes to do a hydroprolapse, particularly over here, and if your rexus is inadequate, then a Sinskey hook really comes to the rescue, and you can rotate it, and then at the same time pushing it down, and then you can bring it out with a Sinskey. A bimanual technique is what you would recommend if the rexus is small. It's a brown cataract, so you use 2 instruments over here. I don't have a video of it. So what you would do is a iris depositor on the left hand and the right hand if you're a right-handed surgeon with a Sinskey hook, and then bring it up, and then take the depositor underneath the lens, and then you rotate it out. The risk with that technique is there's a high chance of zonal dialysis, but if you do it right, it's pretty good. When you become a little advanced, you can go for the tumbling technique. You just tumble it down, and it's not difficult, but I would recommend you to become first an expert surgeon before trying something like this. Nucleus delivery. See, the concept of SICS is that the left upper lip, when you press it, your instrument is against the left upper lip of the tunnel. The AC is formed. So this is when you do the rexus and the IA. When you depress the lower lip, that is when the AC becomes shallow, and you want the nucleus to come out. That is when you do it. So it's good to give counter traction. If you have a superior rectus brittle suture, you can pull it, or you can use the forceps at 6 o'clock to give that counter traction. Visco expression is what a lot of people do. It's very endothelial friendly. Put visco over the top of the nucleus and then below it, and then you can just prolapse it out. At the same time, you can pull the superior rectus or give counter traction via forceps as well, and it comes out pretty nicely. Softer nucleuses, you can even do a hydrodissection, hydro expression, and with the same maneuvers. Vectis is when you use a vectis, you need to grab it underneath the thing. Once you've grabbed the nucleus, that is when you bring it to the tunnel, that is when you bring it closer to the tunnel, and then you depress the lip, and then it comes out, along with giving counter traction. This is another video of a hypermature cataract that I was doing. You grip it. So again, I would say give counter traction only after engaging the nucleus and you press the lower lip over here. This is another video of the same. I'll skip this. Sandwich technique is a lot of people do that. I'm not so comfortable that much with it. You can use a Sinski hook on the top and a Vectis below. Some people use a visco cannula as well, and they inject visco at the same time so that the AC doesn't get shallowed. It's helpful in hypermature cases, particularly when the nucleus is small as well. Coming to cortex management, you should use a good Simcoe cannula. PC and ALC polishing should always be done. Get a good hold of the area, sweep it around, and then bring it to the center and aspirate. If there's any area of zonal dialysis, then what you need to do is you need to do a tangential aspiration. That's the rule. Coming to IOL implantation, in the beginning stages, you can go it with visco, but once you become comfortable, you can use any irrigation as an AC maintainer. You can use the Simcoe cannula as an AC maintainer, as you see over here. And with that, this is under visco, and you can just implant it, rotate the IOL into the bag. It's very important to put the IOL into the bag. So this is another example of that. So over here, what I'm doing is, you can see I'm using a Simcoe cannula, and I've put it in my left hand, and I'm going to put it on the side port, and then put the nucleus inside in the bag. It's nice, and then same instrument, same forceps that I'm using, I can actually just put it into the bag. I'll skip this. Whenever you have a doubt, so suppose if you're doing hydroimplantation, I'm using the irrigation part of a bimanual eye over here, always inject visco over here, and then you can rotate it into the bag. It becomes easy. Whenever in doubt, inject visco. It really helps. Regarding closure, always suture your tunnel whenever you're in doubt. You can cauterize this conjunctiva, or you can even give a subconjunctival injection. Post-operatively, the medication as such. And thank you so much for this opportunity.
Thank you, Doctor, for a very nice presentation about a very common topic which everyone must be doing. So it was a very nice presentation. Thank you. Any question, we can keep it to the last so that all the talks will be finished and we can discuss in elaborate. Next is Dr. Muralidhar. He is going to present about the childhood myopia key points.
Good morning, and I thank Dr. Santosh Navar and team for having invited me. I'm pediatric ophthalmologist at the Eye Foundation, Coimbatore, and I'll be talking on key points in childhood myopia. So let us first understand the magnitude of the problem. Around 23% of the world population is myopic. It has doubled since the last decade, and the prediction is that with the current mathematical modeling, that half may become myopic by 2050. So in some countries, especially in China and Singapore, Taiwan, almost 70 to 80% of the adults are myopic, and 20% of children have high myopia. So it has been labeled as an immediate concern by the WHO for elimination of avoidable childhood blindness. So high myopia not only decreases the quality of life, can also predispose you to cataracts, retinal degeneration, glaucoma, and more than 8 diopters of power implies almost 8 times the risk of retinal detachment, and more than 6 diopter, 14.4 times the incidence of glaucoma as in normal population, and 2.3. So myopia is an emerging problem, and it is rapidly increasing. And so I'll just cover some points on this, and the possible reason behind this spike is possibly an increase in near work and less time spent outdoors, less sun exposure, some genetic factors as well, because if the adults develop myopia, the child is also more likely. Reading in dim light, these have been blamed for the spike, especially the COVID lockdowns. They have been blamed as possible reasons for the myopia pandemic. And I'm sorry. So this is kind of a flowchart that we use. So let us say you identify a child at risk of myopia progression, more time spent indoors, and parents myopic, and more hours spent on reading, especially during the COVID pandemic. Almost all schools have made laptops mandatory. So if the answer to all this is yes, it's mandatory. This is a public health education. I would suggest that you can put these videos in your clinics, and you need to act, because myopia is an emerging pandemic and India is no way behind. So if 23% of world population is myopic, India cannot be behind, and so we really don't want to be at the peak of the curve. So evaluation, we typically follow the guideline that if the child is less than 5 years old, we do an atropine refraction once a day for 3 days we give, and CTC is cyclopentolate, tropicamide cyclopentolate. So if the child has some kind of a contraindication like a history of seizures in particular or a previous history of cyclopentolate psychosis, we need to train our staff to ask for these leading questions. Does the child have any neurological problems? Has the child had issues with cyclopentolate before? In those cases, you can use homatropine because cyclopentolate crosses the blood-brain barrier. The advantage is that it has shorter turnaround time, rapidly acting, and the effect usually goes away in 8 hours. Some may have till 72 hours, but homide is slower acting and longer acting also. Effect will be there for 5 to 7 days. So a comprehensive ocular exam is mandatory. So these are the American Academy focal point guidelines. These are for normal children, not for those with cerebral visual impairment, in which case our limits may be lower. So if you have an infant or toddler up to 1.5 diopter of myopia, usually we don't correct. And for preschoolers, they say 0.25. Practically, it's around 0.5 diopters. So these are the upper normal limits. Above 1.5 diopter, if the child has still 1.5 diopters, you don't worry too much. But if the child has something over 1.5 diopters, you have to monitor the children very closely. But if the child has more than 3. So I hope the distinction is clear. These are the upper normal limits, and these are the clinically significant beyond which you would start prescribing. That is more than 3.5 diopters, or preschoolers more than 1.5 diopters, or more than 1 diopter, you usually start prescribing. In fact, school age, you can even do a subjective refraction and do it. These are the upper normal limits. So beyond which you would start monitoring them for myopia. So this routine screening is indicated if there is a family history, if there is a history of prematurity, if there is strabismus or nystagmus, epicanthus, any syndromic associations, and if there is a head posture. All these children, even without visual complaints, need to have atropine refraction less than 5 years, and above 5 years, dynamic refraction, cycloplegic where indicated. So regards to myopia and strabismus, so remember that when you measure strabismus over a minus glass, it always gives a higher value. So this formula I have taken from my mentor Sharma sir's book. This is measured deviation by the actual deviation, and this is the formula. You would find it in Sharma sir's book. And yeah, so this is a central eye patient who had mild myopia. So note the magnitude of the exotropia.
2, 4, 8, 9.
And when you over minus them, there is some controversy regarding over minus. This is not for everybody. So please note whether they are able to tolerate or not. And only then you should. Come on, madam, I change. Yeah, with the over minus, the occluder is completely occluding the right eye. It is just that it is not seen very well. So with over minus lenses, the magnitude definitely comes down, especially in those with high AC by ratio. But over minus lenses, there is some controversy, especially on effects in myopia progression. So it is not for everybody. So remember that, and now we'll talk on some of the key things that you may have heard across all over: halting or staggering myopia progression. So this is from the WSPO's consensus statement for 2023. So all these possibly they don't work. So remember, there is a distinction between peripheral defocus and DIMS. So this is available on the WSPO's. It's a free download, and so these interventions possibly they don't work. So what really appears to work is more time spent outdoors, more than 2 hours, and reduce near activity. Low concentration, I mean 0.01% or 0.05% atropine eye drops. And DIMS, and these are highly aspheric lenslet, which is a new, this thing not yet commercially available. Orthokeratology and soft multifocal, these possibly, they would work in halting or staggering myopia progression. So I'll first talk on the DIMS.
This technology is based on the peripheral defocus theory. In the myopic eye, rays are focused in front of the retina and in the periphery behind the retina. With a single vision lens, rays are focused on the retina, while there is a hyperopic defocus. MyoSmart with DIMS technology creates a myopic defocus, focusing rays in front of the retina.
Incorporating the DIMS technology, or I mean DIMS technology is available. DIMS is a proprietary term with Hoya, but Zeiss also makes myovision, and EyeShala also makes Stellus.
This technology.
Okay, so this is the proprietary DIMS technology. There is central 9mm, and then there is 33mm diameter, where you have these DIMS lenslets, and each of which defocus by plus 3.5 diopter, each of which defocus by, I mean, surprisingly, there is no issues in traffic safety, as the company themselves say. And even when you ask our children who are on these DIMS glasses, they do not report any issues with peripheral vision. So this myopic defocus, where you make the retinal periphery relatively defocus myopically, possibly it is a likely mechanism of action with ortho-K and multifocal contact lens efficiency also. They are less invasive, so I also prescribe them to pre-myopes. Pre-myopes is the first-time myopia. Normally, they were recommended only when there is myopic progression of 0.5 diopters or more in the first 6 months. But in case you have a sibling who is progressing rapidly or parents having high myopia, I give them even earlier. So the benefit is not known in staggering pseudophakic myopia. So the benefit, this is the benefit, they stagger the progression by around 0.5 diopters over 2 years, and 21% had absolutely no progression over 2 years. So over 3 years and over 6 years, the efficacy of these lenses are sustained. If you thought there was not a very great there was not a very great efficacy, then please remember that even a 1 diopter reduction in myopia reduces the risk of myopic maculopathy by up to 20%. So that's really something, this thing is non-invasive, and there's no issue of compliance because anyway the child has to wear the glasses. So if the child is younger and lower baseline myopia, so the earlier you start, the more efficacy you are likely to get, and there is a chance of rebound if you switch from DIMS to a normal glass. So possibly you would like to give it as long as it is required. So these are the ATOM trial, atropine and myopia trial, and remember this was the range over which it was tried, 6 to 12 diopters. This actually gave much higher efficacy than the DIMS glasses. Almost that was a 60% reduction. This is 70 to 80% reduction in myopia progression. So these are 70 to 80%, that's what I said, reduction in myopia progression. There is some rebound. So the idea is you give it for 2 years and then give a break holiday for another 1 year. If there's progression, you may have to reinstitute atropine. So 0.01% was supposed to have the least rebound, but there are some studies that show that 0.05% is more efficacious, and the rebound is almost the same as the 0.01% atropine. And remember, both in these DIMS as well as these low concentration atropine, there is a certain percentage, 9%, who do not respond to either modality. So whether you can use it in combination or not, we don't have the answers as of yet. Okay, so this is the ATOM, and basically it showed that the rebound with 0.01% atropine given once night was the least, and sometimes we use it twice in case the patient fails to progress, but whether twice daily application or thrice daily application is more efficacious, and whether a child is going to comply, we do not know as of yet. We don't have answers to these questions. Okay, so this is basically the study findings that show, and over 5 years the least progression was in 0.01. Remember, it is not about halting myopia progression, it is only slowing it down, and even these children, they progress by minus 1.38 diopter. If you had not, then they would have progressed by around 4 diopters also. So these are the recommendations, and so if there is less than 0.25 diopter progression in second year, you can stop it. Otherwise, you can continue it until the progression stops. And last 2 slides, these are reverse geometry contact lenses. We are yet to gain too much of experience. Possibly they reduce the myopia, but possibly their efficacy in slowing down myopia is same mechanism as these DIMS glasses. So there is a real risk of keratitis with these, but they say the risk is it is slightly lesser than the other contact lenses, but definitely more than the normal population. We don't have answers on rebound, and don't forget the lifestyle modification like daylight exposure and good posture, lighting, reduced near work, and close monitoring. They go hand in hand with technology. And thank you so much.
Thank you, Dr. Muralidhar. It was a nice presentation and comprehensive, and all the important points you have touched also, because the time is limited, so we are not going to ask you any question. At the end, if we get them, we'll discuss. Thank you. Now it is Dr. Chitra Raghavan, who is going to talk about ectatic cornea disturbance. Is here?
Go to the next call for moderation.
Okay, thank you. Madam, what is your topic? Which one? Okay, she'll be presenting on the management of congenital ptosis.
So keeping in mind that the session is meant for postgraduates, I have prepared my talk accordingly. So I'll be discussing the key points in the management of ptosis, and before that, I'd like to go through how you should evaluate the important points in ptosis workup. So you know that ptosis is basically the drooping of upper eyelid from more than 2 mm. So we can classify it as congenital or acquired, or etiologically we can classify it as myogenic, aponeurotic, mechanical, and neurogenic ptosis. So first,
Slides. Yeah.
first and foremost, you take your children. So first, many times in from here, or what the slides?
You tell
Yeah.
next.
Okay.
It will be awkward, but we have to be.
Okay, so
able to-
this is the performer for the ptosis workup. We start with the visual acuity and pupil. So why it's important to look for the visual acuity? Because ptosis in severe cases, it can cause amblyopia. And it's not the stimulus deprivation amblyopia, which is the most common variety, but it's the anisometric amblyopia, which is because of your pressure of the eyelid over the cornea that causes astigmatism. So the most important amblyopia is the anisometropic, and followed by stimulus deprivation amblyopia. Pupillary examination is important because sometimes in neurogenic ptosis, like in Horner syndrome, you may get meiosis, and in third nerve palsy, you may get mydriasis. So you have to look for the head position of the patient. In bilateral severe ptosis, patient may have some chin-up position. Also look for frontalis overaction, because in severe unilateral ptosis, patient may have a raised eyebrow because of overacting frontalis muscle. Look for the position and presence of lid crease. So if the lid crease is absent, then we can say it's a ptosis with poor LPS function, and usually seen in congenital variety. Whereas if the lid crease is present, then it indirectly denotes that the LPS function is good. It's high and deep in aponeurotic kind of senile ptosis, whereas it's absent or faint in congenital ptosis. MRD, that is the margin to reflex distance, is important to calculate the amount of ptosis, and we can divide or grade the ptosis accordingly into mild, moderate, and severe variety. In the mild ptosis, the amount is 2 millimeters, and moderate is 3 millimeters, and severe is 4 millimeters or more. Always look for a compensatory response in the other eye, and there may be a lid retraction because of the Herring's law of innervation when there is a unilateral severe ptosis in one eye. To measure the LPS function, you ask the patient to look down and take a ruler and ask the patient to look up. And the excursion of your eyelid from maximum down gaze to maximum up gaze will signify the amount of LPS action. And you can grade it into fair to poor and good. Poor LPS action, we say if it is less than 4 millimeters, fair is 5 to 7 millimeters, and good is 8 or above. Now you have to look for lid lag in congenital variety of ptosis, because the LPS muscle is dysfunctional, it's fibrotic, and it's not able to relax properly. So whenever the patient will look down, you will see some lid lag, and lid droop is there in aponeurotic variety of senile ptosis. Bell's phenomena is very important preoperatively. If the Bell's is poor, then we do not go ahead with the surgery. Bell's is the outward and upward movement of the eyeballs when patient tries to close the eyelids. So how you can grade it? If less than 1/3 of the cornea is visible, then it's called as a good Bell's. 1/3 to half of the cornea is visible, it's a fair Bell's. And if more than half of the cornea is visible, it's poor Bell's. Marcus-Gunn jaw winking phenomena, it's a variety of complicated synkinetic ptosis. When the patient moves the jaw, the eyelid also moves along with. There is an eyelid retraction on the jaw movement because of the supply of the mandibular nerve to the LPS muscle. It's important to do a dry eye workup, triofilm evaluation, and corneal sensation or Schirmer's test before any ptosis surgery. Always look for old photographs whenever in doubt that it's a congenital or acquired ptosis. In myasthenia gravis, you can just do an ice pack test in the OPD. And phenylephrine test is of paramount importance if you are planning to do MMCR or facial lata surgery. In blepharophimosis syndrome, you must look for any family history. Always ask the patient for any morning edema in cases of blepharochalasis. In myogenic ptosis, you may have decreased extraocular movements and poor Bell's phenomena. So in these cases, you may prescribe crutch glasses and you should not go ahead with the ptosis surgery. Surgical management is aimed at the functional goals of clearing the visual axis as well as the aesthetic goals of symmetrical eyelid position. Now, when you should do the surgery, it's advisable to defer it till 3 to 4 years of age until and unless it's unilateral or severe ptosis causing amblyopia. Surgical procedures are many, and you can decide according to the amount of ptosis and LPS action. So in mild ptosis with good LPS action, we can plan for Fasanella cervet surgery. So this is a surgical video of Fasanella cervet. We mark the lid crease. This is the local infiltration that I'm giving, xylocaine with adrenaline. The lid traction suture is marked. Can you just forward it a little bit? So I mark the superior edge of the tarsus. Then a traction suture is passed at the superior edge. And again, 3 sets of traction sutures will be passed from the fornix to the near the lid margin. Then the amount of tarsus to be resected is decided by the amount of ptosis. So for every 1 mm of ptosis, we resect 2 millimeters of the tarsus. So here we are measuring around 4 millimeters of the tarsus because patient is having 2 mm ptosis. So after clamping, we just cut it with a Stevens sternotomy scissor, and we directly close the incision by, this is the atriovicular suture. We don't want to put the knot on the inner side because it will rub on the ocular surface. So we put the knot outside and interiorize the suture, and with the help of continuous running suture, we'll close the conjunctiva along with the remaining part of the tarsus. So this is the end of the surgery, and patient has a symmetrical eyelid contour matched with the other eye. And this is the post-op photograph. LPS resection is a very popular mode of ptosis surgery that we can do in all variety of ptosis which have some amount of LPS action, whether it's a mild, moderate, or good severe ptosis. So this is by transcutaneous route. After giving the skin incision, the orbicularis is separated. Then we open up the septum. This is the LPS aponeurosis that you saw. Then we can evert the lid to inject the subconjunctival xylocaine with adrenaline for the facilitating the dissection underneath the LPS muscle. So here I'm separating the LPS aponeurosis from its attachment over the tarsal plate. And then depending upon the amount of LPS that you have to resect, you have to do the dissection. So this is the tarsus where I have to advance the LPS. This is the white line. That is the junction of the aponeurosis and LPS muscle. So I am measuring according to the amount of ptosis, and then I'll pass a suture. This is a 6/0 nylon suture. So first we'll take it from the LPS muscle, then to the tarsus, then again through the LPS muscle. And then we'll check about the position of the eyelid over the limbus. So if it's a good LPS action with mild to moderate ptosis, we can leave it 2 mm below the limbus. So 3 such sets of sutures are passed, and then the remaining part of the LPS muscle is cut, shortened. In the end, we pass the lid crease sutures and close the incision. Post-operatively, we have to look for leg ophthalmos, lid lag, and take care of the ocular surface. Lastly, I would take you through the frontalis suspension surgery. And the most ideal material to use for the frontalis suspension is the fascia lata. And we can use this tensor fascia lata. We can retrieve it with the help of a stripper, or we can use the long scissors to retrieve it. And this surgery can be performed in the children more than 3 years of age, and in adults there is no contraindication. I am doing this surgery under local anesthesia. If the surgeon is not comfortable, it can be done under general anesthesia. So this is the tensor fascia lata that we are removing. So around a strip of 10 centimeters is required for any kind of frontalis suspension surgery. You divide it into 2 to 4 strips. Then depending upon your surgical technique, you can mark the incision. This is I'm doing by the modified Crawford's double triangle method. So this is how we pass the AIOC in double triangle technique. This is the pre and post-op pictures. In blepharophimosis syndrome also, it's a preferred method. So to conclude, I'll say that ptosis remains the most common but is still the most controversial oculoplastic entity, and careful preoperative assessment, judicious surgical planning and execution gives the best outcomes. Thank you for your patient listening. Thank you. Okay, if we have time, then of course. So, what are the materials that you commonly see for frontalis suspension surgery apart from AIOC? Sling is the name for suspension. Okay, what is the material? It is the silicone. Okay, silicone rod is the one which is very easy and short procedure. Okay.
Good morning, everyone. At the very outset, I would like to say thanks to Dr. Santosh Honavar, who has given me this opportunity. And with regards to the dais, dignitaries at the dais, madam, I start with the age-related macular degeneration. What are the key points? So we all know that ARMD, it leads on to central visual impairment with the abnormalities of the RPE and Brooks membrane. There is a CNVM formation. There are focal areas of RPE loss, and subretinal sub-RPE hemorrhage or serous fluid or subretinal fibrosis is the sequelae of this ARMD. In this picture, we can see that drusen, which is the early dry AMD, is seen in early AMD cases as a sub-RPE collection, and photoreceptors loss and severe vision loss with fluid accommodation occurs in ARMD in advanced stages. Symptoms are the decreased visual acuity, insidious, or it is sudden in onset, blurred vision, distorted near vision, positive scotomas, visual distortion, metamorphopsia, micropsia, and sometimes vague visual complaints are there. Dry AMD usually does not cause severe vision loss. However, wet AMD is the major cause of severe vision loss. There are various risk factors. There are modifiable risk factors like cigarette smoking, sunlight exposure, serious diseases, hypertension, obesity, hypercholesterolemias. Cigarette smoking is very, very important in this modifiable risk factors. And there are non-modifiable risk factors as well. So ARMD, it can be non-exudative, it could be exudative, it can be geographic atrophy, or it can be CNVM or this dry ARMD, geographical atrophy, it's an advanced form of dry ARMD, typically begins in the parafoveal area, and it increases in the circumferential pattern. Geographical atrophy is a well-defined circular area of size more than 175 micrometers. Progressive loss of areas of RPE, photoreceptors, and underlying choriocapillaries, they occur. On OCT, absence of the RPE, inner segment ellipsoid zone, external limiting membrane, and outer nuclear layer occurs. So what are the different types of CNVMs? Type 1 is the occult CNVM that occurs beneath the RPE. Second is the classic CNVM. It is above the RPE. It is also called as type 2 CNV. Type 3 is the retinal arterial proliferation. Anastomosis occurs between retinal and choroidal vessels, also called as aneurysmal or PCV, polypoidal choroidal vasculopathies. According to the position, it can be subfoveal, juxtafoveal, extrafoveal, or peripapillary. So this is the first CNV type 1. You can see in the diagram. It is the sub-RPE lesion which is occurring. Type 2, it is above the RPE. And this is the CNV type 3. We can see a lot of distortion is there in the layers. There is schisis also. There is sub-RPE collection and proliferation. Choroid is also not normal here. You can see. So aneurysmal CNVM or the PCV, it is a spectrum of conditions characterized by pachychoroid in which disturbance in choroidal circulation occurs. PCV presents a serosanguinous maculopathy. Generally, a patient presents with sudden loss of vision or scotoma, and once you do an indirect ophthalmoscopy or plus 78D examination on slit lamp, what you see is a serosanguinous. So there is collection of hemorrhage there with sub-elevation in the foveal area. So on FA, in the late phases, it shows intense localized area of hyperfluorescence. On early ICGA, polyp-like lesions are seen. So a combination of anti-VEGFs and verteporfin PDT, they are commonly used in such cases of PCV. So we can see polyp formation here in case of PCV. There is a dome-shaped PEDs there. Hyperreflective dots can be seen. Very important is to see that the whole retina, it is lifted up. It is lifted up, and you can see that RP elevations are there. There are very high PEDs are there. Tenting is there. They are also called as finger. Impressions are there like fingers. So this is PCV, but the upper layers are nearly normal with few hyperreflective dots. This is very significant in this. Another picture of the same lesion, PCV. So diagnosis, it is based on Amsler grid, Snellen's chart acuity, slit lamp biomicroscopy, fundus fluorescein angiography, ICG, OCT, and OCT angiography. We can see that in fluorescein angiography, we don't see the occult lesions as good as we can see in the ICGA. You can see the hyper intense lesions on OCTA. So how do we differentiate between classic CNVM from occult one? So classic CNVM, it is a rapid and early filling of dye is there. However, in occult CNVM, slow and late filling is there. Classic CNVM is bright filling of dye. Less intense filling of dye is seen in occult CNVMs. Lacy patterns are seen in classic CNVMs, and stippled hyperfluorescence is seen in fibrovascular PEDs. Also, they are described as classic. It can be predominantly classic CNVM when it occupies 50% of the lesion. It is called as minimally classic CNVM when it occupies less than 50% of the lesion. Occult with no classic CNVM has a 0% component of classic CNVM. So fluid is an important part. We always know that if there is fluid, we have to inject anti-VEGFs, or there can be disciform scar where we know even if anti-VEGFs are given, we are not going to get good vision. This is important. Occult versus classic CNVM. We know that type 1, it is seen in ARMD or polypoidal choroidal vasculopathy or CSCR, whereas classic or the type 2 is seen in ARMD, myopic CNVMs, inflammatory CNVMs, angioid streaks, and choroidal osteomas. Type 1 CNVMs, they progress slow and respond slow. Type 2 CNVMs, they progress fast and resolve fast. So how do we treat dry ARMD? It's not, we always give some antioxidants in the form of zinc oxide, copper, vitamin C, E, lutein. AREDS 1 and AREDS 2 study are there for it. However, most important is to give anti-VEGFs when there is a wet ARMD, when there is fluid is there, or distortion because of the CNVM or the wet ARMD. So Macugen, Avastin, ranibizumab, aflibercept, brolucimab, they have come. Now there is faricimab also. So brolucimab, we know, is a low molecular weight VEGF antagonist, and it is found to be non-inferior to aflibercept with every 12-week dosing. That is important. And with faricimab, it is the 16 weeks dosing. So all the more important. It has been approved for use in US in early 2022. So there are various important trials associated with wet AMD. We should know that anchor studies there where it was concluded that ranibizumab, it provided greater clinical benefit than verteporfin. So, Marina studies there, PIRE, where ranibizumab is inferior to monthly injection, then view 1 and view 2. Pro-Renata treatment, PRN treatment is there. Here it is, the patient is followed up on a monthly interval and treatment is done based on visual acuity and SDOCT. Then there is a Pieronto study where the conclusion is that comparable visual outcomes from phase 3 clinical studies, but only fewer intravitreal injections were required in this study. Harbor study, CAT study, and then treat and extend protocol, which is very much followed nowadays. So TREX is another variable dosing regimen. The advantage is reduces the number of visits for patients to the clinic and thus improves patients' compliance. Disadvantage is that the regimen may result in unnecessary overtreatment of patients, and it has been reported that long-term use of anti-VEGF injections, they might result in geographic atrophy in TREX treatment. Other treatment modalities are laser photocoagulation for fovea-sparing CNV lesions. It can be PDT, or it can be submacular surgery for patients with wet ARMD. Macular translocation surgery and mechanical displacement of subretinal hemorrhage with gas can be made. Pneumatic displacement of submacular hemorrhage using intravitreal gases or a gas injection with face down positioning is also done. Radiation therapy is also considered in CNV in wet ARMD. We have to do OCT and see ourselves, not very much dependent on the technicians, because sometimes it is mislabeled. You can see that the NSD is visible here on this side. This is the NSD scene, and one can, if you don't do it properly, if you don't do OCT properly, you can miss that macular hole, and injection is given unnecessarily for this surgical treatment. So conclusion, it's a diagnosis of ARMD is vital. Always try to find the cause of CNVM. Avoid unnecessary injections. Check the vials and note the details. Correct technique should be learned, and asepsis is mandatory. Thank you.
Thank you, Dr. Manisa. It's a very nice presentation, and you finished in time. So we can take 1 or 2 questions from the audience if they want anything. Any doubt? Or since it is for the postgraduate also, madam, also you can ask 1 or 2 questions if they have understood or not. If no doubt, then we'll pass on to next speaker, Dr. Anil, I think. Dr. Anil Radhakrishnan. Is there, no? Huh. He'll be talking about the penetrating keratoplasty, the key points.
If you look at the corneal transplant or our program all around the world, I think there is a general trend towards more of lamellar procedures. And this is one representative Western data, which tells you that about close to 60% of people have endothelial pathology, and endothelial replacement is the thing to do. But is penetrating keratoplasty really fighting for space? If you look at the data from India, that is a more recent data, that is a very good data by Dr. Namrata Sharma, looking at the 10 eye banks, we see that infections and corneal scars still remain the major indications for corneal transplant. If you look at the chart there, I think 35% is because of infections. So in a country like India, penetrating keratoplasty is still very relevant. Almost 80% of the surgical work that we do was for penetrating keratoplasty. And it's 12.4. Previously, it was close to 1%. Now it is about 12.4%. All this DSEC, DMEC, and all that is there, but it is much less in comparison to penetrating keratoplasty. Whichever transplant you do, it's very, very important to have a very good preoperative evaluation. We should assess whether the visual acuity is really corresponding to the corneal pathology. If you have a corneal pathology, then you'll have good results. So look at the tropias. If it is a tropia, it tells you that the visual deprivation has been for a long period of time. Then lag ophthalmos should really be looked into. So even if you do the best surgery possible, if you have lag ophthalmos, the graft is bound to fail. So lag ophthalmos, lid pathology, dry eye, all these things should be corrected. And if there is a severe dry eye, it's better not to do a keratoplasty because the graft is not going to survive. Same thing with neurotrophic keratitis and limbal stem cell deficiency. Unless you address it and then only you think of a transplant. Otherwise, it is bound to fail. So preoperative evaluation is most crucial in keratoplasty. As I was mentioning, a thorough slit lamp examination. Special attention should be paid to the vascularization, especially the deep vascularization. If you have more than one quadrant of deep vascularization, the chance of graft failure is much, much more. The inflammatory status, if you have HSV keratitis and if the eye is slightly inflamed and then you're doing a transplant, the results are bound to be much, much worse compared to a silent eye. Again, as I mentioned before, ocular surface should be given proper care. So, slit lamp examination, pupils, lens, then IOP should be well evaluated. And if the IOP is seen to be high, you have to address the glaucoma and then do a transplant 3 months after the procedure. Indirect ophthalmoscopy or B scan should be done to make sure that there is no other coexistent retinal pathology. So I'm not going to the details, but there are outcomes really depend on the disease process that you have. If you have a keratoconus or an isolated central scar, the results are excellent. While if you have something like chemical burns and mild, even moderate dry eye, the results are going to be bad. And if you have neurotrophism, it is better not to touch that patient. So in the procedure, we generally put rectus sutures, and if you have a pediatric keratoplasty or if there is a aphakic status in which the ciliary rigidity is less and the vitreous is likely to come into the anterior chamber, it's better to put a fluoring gas ring. The sizing of the trephine will depend on the pathology, First is the corneal size. If it's a larger cornea, you go for a larger graft. It mostly depends on the pathology. If it's a central corneal scar, you tend to make the trephination as small as possible. The larger the trephine you do, the larger graft you take, you can have more chance of rejection. And sometimes the pathology may be eccentric, and eccentric pathology, again, the chance of rejection is more because you'll be more closer to the limbus and closer to the immune status, and the chance of immunological events will be much, much more. Donor trephination is usually done from the endothelial side. Usually about 0.5 mm oversized graft is that we used. For keratoconus, especially myopic keratoconus, you can use same size graft. And suction trephines are used, like Barron's trephine is there, which can actually give make sure that the tissue does not move while you do the trephination. So you first you inflate the anterior chamber with viscoelastic, make a cut in one area, entry. Then with the trephine, you cut from both the areas. Then you remove it, and over a bed of viscoelastic, you put the donor button. And the video is running. Video chalu nahi. So it's very important, the suture. It's important to put the sutures pass through minimum 80 to 90% depth. Near about 90% would be appropriate. So this is a small video, edited video of the keratoplasty. It is a combined procedure. First, you put the rectus sutures, then fluoring gas ring for stabilization. Because I've been planning a combined procedure, I put fluoring gas ring. Make an AC entry, put a tryptan blue. Then the patient had secondary cerebral degeneration, which I'm removing now. Then you inflate the anterior chamber with the viscoelastic and then do the trephination. Make sure that it is centered as much as possible. You go to about 80% depth and then make the AC entry. And it's important to keep the scissors vertical. If you keep it oblique, there will be a large posterior ledge, which can cause a lot of astigmatism. And even inappropriate graft host, whenever healing happens, there can be some tissue there. So sometimes you'll have senecae, which can be just cut off. You can actually swipe it with a spatula and see, but quite often it is rigid, and then you have to do this. So I'm attempting a rexus here, but I see that the anterior capsule is fibrous. So I took the Vanas and I'm making a mechanical cut in the anterior capsule and making a large capsulotomy. Do a hydrodissection, a pretty large nucleus, but it has to be just rotated out. And do a Simcoe aspiration as you do in any other cataract surgery. It's not necessary because normally you have a bulging PC, so it is not necessary that you have to be perfectly complete in your aspiration. If you remove most of it, just leave the few fibers which is sticking on the PC and put the lens as much as possible in the bag. If you put it in the bag, the chance of it getting dislocated later in the process of keratoplasty would be much less. Then you put the corneal button and start the suturing. So first you put the 4 stay sutures and make sure that the graft is proper. So in case there is some incompatibility there, or you feel that one area it is not properly approximated, you have to re-put the stay sutures and then you put the fill-in sutures. Usually interrupted sutures is that what we do, and continuous suturing nowadays have gone out of vogue. The outcome of keratoplasty basically depends on three factors. First is the recipient pathology, probably the most important thing. The second thing is the donor quality. If you have a good quality donor, then the results are bound to be better. Then the care, both the surgical care that you give and the post-operative care. It's most important to follow up the patient. It's not like cataract surgery, you just can't forget the patient. You have to keep the patient on a 3-monthly follow-up. And if there are any signs of rejection, like photophobia, redness, or decrease in vision, patient has to repeat immediately. So every patient would be counseled preoperatively very well that it is important to have a lifetime follow-up. Just a brief mention of therapeutic keratoplasty. Therapeutic keratoplasty is an emergency procedure. It is done in conditions where the medical treatment fails. It is only if the medical treatment fails you consider therapeutic keratoplasty. It's a totally different ball game. You'll have a lot of fibrotic membranes and all that. Even if the patient has a cataract, generally we don't do cataract surgery along with it because the risk of endophthalmitis would be more in such a case. So I'm not going into the details in the interest of time. So I would like to conclude saying that penetrating keratoplasty is very relevant even in this time when lamellar keratoplasty is ruling the roast and where you hear mostly about lamellar keratoplasty everywhere. But in countries like India and in other developing countries, penetrating keratoplasty is still very relevant, accounting for about 80% of transplants. And if given proper care and follow-up, it is a highly successful procedure. Thank you.
Thank you, Dr. Anil. Actually, it was a very nice presentation. Now, also, there is a lot of indication for penetrating keratoplasty, and there is a lot of success also. So, you have covered it very nicely. After that, the second is component keratoplasty. Then, after that, we'll take questions. Please stay for another 10 minutes. Let Dr. Tuhin finish the component keratoplasty. Glaucoma, medical and surgical aspect, then uveitis, I think. Uveitis.
Okay, good morning, everyone. At the outset, my sincere thanks to Dr. Parthobishwas and Dr. Honavar for this opportunity. Respected chairperson and my dear colleagues. So Dr. Anil has already talked about this full thickness graft. So now I'll be talking on this component keratoplasty. So we all know that this component keratoplasty has revolutionized the field of keratoplasty. So earlier days, what happens that we are going for just for simple reason like corneal scar, anything like that, we have to take this whole cornea out and put this donor cornea here. So in component keratoplasty, that is tissue-specific keratoplasty, where just we are taking out this only the tissues which are they have pathology, and then we are putting this donor there. So advantages are that decreased risk of graft rejection compared to full thickness graft, avoidance of complications associated with open sky procedure, and more utilization of one donor cornea for multiple recipients, which have a value in developing countries like ours, where there is a dearth of good quality donor tissues. So if we look at this classification, Bowman's layer, that means transplantation, which is used in advanced keratoconus. Then for the stroma, it is cell, that means superficial anterior-leveler keratoplasty, then ALTK, then DALK, and then endothelial keratoplasty, which will be again DSEC, DMEC, and PDEC. So I'll be covering everything step by step. So PK, the main advantage is that it is easy and conventional, less instrumentation, surgeon's familiarity, and smooth learning curve. But for EK, we have long learning curves, and the main advantages of EK over PK is that no intraoperative and late suprachoroidal hemorrhage, faster visual recovery, better refractive stability, no wound, suture, and surface-related problems, and strong globe integrity. You can see here that there is some sort of do we have this pointer here? In PK, what we get that because of this tissue-related these suture-related problems, all those things, we can see this infiltrate, that suture erosion, all those things, which will not be there in case of this endothelial keratoplasty. So endothelial keratoplasty, there's DSEC is descemet tripping endothelial keratoplasty and DMEC is descemet membrane endothelial keratoplasty. Agarwal people, they have this venture about this PDEC, where is P-descemetic endothelial keratoplasty. So only those groups are using this PDEC, but mostly DSEC and DMEC are quite common these days. So in DSEC, this corneoscleral incision is made, and then descemetes and endothelium is stripped from the posterior surface. So here this tunnel is made, and then we are stripping this descemate and endothelium, and then putting this endothelium from the donor area, and then putting it here. So in DSEC we are adding this another part to posterior stroma, and in DMEC only just endothelium along with the descemate membrane. So indications are like that: Fuchs endothelial dystrophy, PPMD, CHED, Sandler's dystrophy, Sandler's syndrome, and postoperative cases like PBK or ABK, failed recent penetrating keratoplasty, other causes like post-traumatic, post-HSB endothelitis. So now I am showing this is a case. Why can you come? Okay. So this is a case who had this failed therapeutic graft. So in cases, first we have to strip this descemetes membrane. This is quite thick, and there was retrocorneal membrane. Otherwise, in failed therapeutic graft, you may not strip this descemetes membrane. That is called end-dissect. Here, just we are taking this endothelium as well as this retrocorneal membrane, and then just taking it out, and then can you fast forward it? Now we have to measure this. So here this graft size should be 1 millimeter smaller than this previous graft size, and it should not this overlap, and it should not go beyond this graft host junction. Then we have a granular dissection of the donor tissue, and then took this, and then you can insert it by either take-a-fold technique, or even you can use this tissue glide, or even you can go for this needle push technique also. So in my hand, I feel personally that this by this take-a-fold technique is quite good. And then after 10 minutes, you should go for fluid air exchange. So in DMEC, what you have to do that? First, you have to strip this hypertrophied epithelium, and in these cases, this DM scoring should be larger than this graft size. So almost from the limbus to limbus, and then took out this. I have to peel this descemetes membrane from the donor tissue. It will come very easily. Just you have to learn only 2 or 3 cases, then you can do it. Even I also felt that I cannot learn DMEC. I was doing DSEC, and then suddenly, after 2-3 cases, I felt that it is quite easier than DSEC also. Then you have to put this stamp. Then after this peeling this descemetes membrane, you have to take it in our customized injector. This is customized injector, and then you have to just transfer. You can see this stamp, which is, you have to see that. Sometimes you may put some viscoelastics to see the stamp over the cornea. And after 30 minutes, we should go for fluid air exchange. So what are the advantages of DSEC over DMEC? DSEC, this is quite, learning curve is quite easy, and this need microkeratome. But in DMEC, there is less instrumentation. Graft manipulation is quite easy in DSEC in comparison to DMEC. And wastage of tissue, initially it was more with DMEC, but after few cases you can learn and both will be same almost. And speed of visual recovery will be quite rapid in case of DMEC than DSEC. And the main advantage of DMEC is that you will not have much, the rejection rate is quite low in comparison to DSEC. Now coming to SALC, ALTK and DALC. In all these cases, there will be preservation of endothelium, faster visual recovery, strong globe integrity, and better chance of secondary refractive surgery in future if needed. And there is a large pool of donor tissues. So in SALC, it involves microkeratome-assisted anterior-lamellar keratoplasty for another anterior stromal corneal opacities. A superficial keratectomy of around 130 to 150 micrometer is performed depending on the depth of the scar. And in case of ALTK, this depth is 250 to 350 micron. Okay. And in all these cases, so it will be this ALTK, this keratome, with these machines, we have to remove this scar from the both donor as well as from the host tissues. And the advantages of microkeratome is that it keeps a smooth optical interface and thereby leading for better visual outcome compared to manual dissections. But even with manual dissection, the results are quite good. So who might get benefit? Pathology limited to anterior stroma like corneal scar, trauma or infectious keratitis, corneal degenerations like BSK, spheroidal degeneration or segment nodular degeneration, corneal dystrophy like granular lattice or macular dystrophy. All these patients can get from this ALTK or ALK. Now coming to DALC. So in DALC, we have to go for this maximum depth. That is this almost, that only are keeping this Descemet's membrane, Duas layer and endothelium. So DALC is most reproducible, highest chance to expose pre-Descemet layer, almost 85 to 90% cases. Ma'am, can I take 2 or 3 minutes more? Just there are not many presenters here now. So the least risk of perforation during dissection. So this is a case of so after removing this anterostromal cap, then you have to go almost center by using 26 or 27 gauge needle and then go for DALC, big bubble formation. So it is a type 1 bubble. You can see that this bubble, this gas is spreading from center to the periphery. So you can see that this is the area of bubble formation, and then you have to give a sharp dissection, and you can put some sort of viscoelastics for slow egress of the gas, and then put a stabs paracensis incision, and then complete the procedure. Okay, sometimes we have to when this big bubble is contraindicated, very stiff cornea with extreme thinning or descemetocele, if there is apical scarring or old hair drops, and when DALC is vital, like patients with Down syndrome with ocular surface disease or very large grafts, in those cases we have to go for layer by layer DALC procedure. Here, okay.
Please finish quickly. Other speakers have to go out to some session or they have to flight to catch.
So this is layer by layer talc. Okay. So anyway, if you have any questions, I'll be happy to answer.
Yeah. Now both the keratoplasty sessions are finished. Then any doubt anyone can ask now. Otherwise, we'll go to the glaucoma session. Cover the key points in medical management of glaucoma. First, let me thank the organizing committee for giving me this opportunity. So I have to cover this key points in medical management. I don't have any financial discourse to make. As we all know, glaucoma is a chronic progressive optic neuropathy with characteristic structural and functional defects like the visual field defects. The raised IOP is only the most important risk factor. It's only the most important. It is not qualifying the definition of glaucoma. It is neither necessary nor sufficient for diagnosis of glaucoma because NTG we don't have a raised IOP, and if the IOP is raised in OST of ocular hypertension, that is also not glaucoma. So IOP is neither necessary or sufficient, but it is the only factor which can be modified. So by controlling the IOP, we can halt the process of retinal ganglion cell death, which is the cause of the glaucoma. So what is the fundamental goal of glaucoma management? We have to maintain the visual function of the patient throughout his life. Normally there occurs some amount of death of the ganglion cell, like in the past graph, the blue one, that is the normal aging process. The normal aging process also some amount of retinal ganglion cell loss occurs. But in glaucoma, it is much more accelerated. So we have to reduce this accelerated rate and bring it to that of an age-dependent one. So that by that, the visual function will stay with the patient throughout his life. And treatment is directed towards IOP reduction because only that is in our hand. Nothing else has been proven. So various options for lowering a IOP are medical, laser, surgical. Medical being the most common. Almost 75 to 80% of all the glaucoma cases are treated medically. So we have these medical medications, IOP lowering medications, which are the top one is the prostaglandin analog. We have also beta adrenergic antagonist, alpha adrenergic agonist, carbonic anhydrase inhibitors, cholinergic agents like pilocarpine, and the newer addition to the armamentarium is the ROCK inhibitors. The ROCK inhibitors or ROCK kinase inhibitors are nowadays it is the recent most treatment, and two molecules are there. One is ripasudil, another is netarsudil. Both act by increasing the trabecular outflow, and this they do by the directly acting on the trabecular and squamous cell cells. Previous to that, none of the medications were using the trabecular meshwork outflow. So they were acting either on the aqueous suppression or they were acting on the uveous scleral outflow. Apart from the pilocarpine, which is not used much nowadays due to the toxicity, but these molecules are going to be proven very effective because it acts directly by the trabecular meshwork, which is the main cause of the glaucoma, main registration factor. So they cause almost 20 to 25 reduction. Some conjunctival congestion are reported, but they are usually mild and transient. They do not stay for a longer time. Some corneal vorticillata has been reported with the netarsudil. And another new one is the latanoprostene bunode. It is a nitric oxide donating prostaglandin F2 alpha analog. It is basically a latanoprost. When it is instilled, it is metabolized into latanoprost. And another moiety is that donates the nitrous oxide. The nitrous oxide part usually increases the trabecular outflow, and the prostaglandin increases the uveoscleral outflow. So by this dual mechanism of action, we are expecting to get a better IOP control with the latanoprostene bunode. So these are the new drugs which are already come, and many more drugs are in the pipeline. And basically the drugs broadly are classified into either they suppress the aqueous, that the inflow, or they enhance the outflow mechanism, that is the drainage. Drainage again can be through the trabecular outflow or can be through the uveoscleral outflow. PG analogs act through the uveoscleral outflow and ROCK inhibitors act through the trabecular outflow. And in the aqueous suppressant group, we have beta blocker, alpha-2 agonists like brimonidine and carbonic anhydrase inhibitors. So target IOP is a range of IOP within which the progression of glaucoma and visual field loss will be delayed or halted. But it is not a fixed number. It is going to be changed. After seeing the progress of the glaucoma, we can change the target IOP. But remember, it is only a range, not a number. And it should be individual because there is no fixed target IOP range which is applicable or which is adequate for all the patients, and it is again have to be specified for each eye because both the eyes are not in the same stage of the disease, and it depends upon the damage at baseline, untreated intraocular pressure, life expectancy of the patient, additional risk factors, and disease progression. This is the varieties in which we have to see, and we have to mark whether there is any risk factors for progression. If the risk factors are severe damage in the other eye, family history of blindness for glaucoma, thin central corneal thickness, that is also indicates rapid progression, and systemic factors like transient ischemic attack and pseudoexfoliation. If these additional risk factors are present, we have to set the target pressure at a lower level. In this graph, we can see that the number 1 is the normal aging process, and D is a slow progressor, and B and C both have the same rate of progression and same level of damage at the level of presentation. But B is of an elderly patient who will chances of his going to blindness is much less than the C, and E is a very rapid progressor. So we have to be really aggressive about his treatment, and we have to make a balance between the optic nerve damage. We have to prevent the optic nerve damage. Also, we have to avoid the side effect. If we take more vigorously, then side effects will be much more, and patient's quality of life will be really hampered. So we have to make a balance between these two things. Then Ramajit, Ciota and all in the IGO, they have published a very simple article. For early glaucoma, they have fixed it as less than 17. For moderate glaucoma, it is less than 15. And for severe glaucoma, it is less than 12. Early glaucoma means Cobb-Disc ratio is between 5 to 7. Moderate glaucoma, it is between 7 to 9. And severe glaucoma, it is more than 9. Similarly, in the field damage, if it is less than, if the field damage is not affecting the central 10 degree, then it is a mild case. If it is affecting the central 10 degree, but it is only in the one hemisphere, then it is a moderate one. If it is affecting both the hemifield, then it is a severe one. Accordingly, we have to fix a target pressure. So how to initiate? Always start with the most potent single drug. Usually PG analogs are the first choice of therapy because it's quite effective, 30% reduction and once daily dosing. For that, compliance is better, and we have to, it has got a very good safety profile because nil side effect almost it's there, but it is not given or not advisable in uveitis, CME and herpetic keratitis. If it is not advisable, then the next line of treatment is the beta blocker, which causes 20% reduction, but we cannot give that to a cardiac failure patient or COPD patient. So how to proceed? It is usually ideal to start with a monotherapy unless the pressure is very high or the disease in a very advanced stage. If that it is tolerated and responsive, that is well and good. Responsive meant at least 15 to 20% reduction from the baseline. Then we can tell it is responsive. Less than that, it's not responsive. And then we have to see whether it is reaching the target pressure. If it is reaching the target pressure, then we have to only periodically verify the endpoints. But it is not reaching the target pressure, then we have to add a second drug. But if it is not tolerated or not responsive, then we have to switch the drug. Addition will not help. And again, we have to look for the efficacy, tolerability. If there is poor response to several different mechanisms, then you have to think twice. We have to rule out the angle closure because angle closure amount is there. It will only respond to laser iridectomy. It will not respond to medical therapy. How many more drugs you are going to use? And we have to consider also non-compliance because if the patient is not putting the drop properly, then there is no help. If the second drug is required, we have to consider safety, tolerability, convenience of the dosing, but we have to say the efficacy also. But their IOP lowering should be at least additional 15%. It should be additional 15%. And we have to choose drug with different mechanism of action that complement each other, like prostaglandin analog with either beta blocker or carbonic anhydrase inhibitor. Carbonic anhydrase inhibitor and beta blocker, they are aqueous suppressant, and PG analog, they are outflow enhancer. So they will complement each other and is better combination. And among the different fixed combinations, timolol can be combined, available with combination of all the drugs, and non-timolol group, we are only brimonidine with binzolamide and natarsudil with latanoprost. These are only two mechanisms where it is not combination. And fixed drug advantage is there, better compliance and number of drops are less, so patient will have less toxicity from the side effects. Side effects can be due to preservative or it can be due to the drug itself. PG analog can cause lengthening of the eyelashes and periorbital prostaglandin associated periorbitopathy, which is problematic particularly if only one eye the patient is using the drop, and keratoconjunctivitis and allergic reactions are also there. And preservative can cause and exacerbate the pre-existing OSD and cause dry eye and meibomian gland dysfunction, and it affects also BKC is particularly notorious for affecting the ocular surface, and long-term BKC will also hamper the success rate of the trabeculectomy. So we have to keep those in mind, and to reduce OSD we can use preservative-free or at least BKC-free medication that will give relief to the patient, and we can use fixed combination. So if we are going to fixed combination, then it is better, and the patient will have only 2 exposure to the preservative. And practical consideration, we have to demonstrate the punctal occlusion because that will reduce the systemic side effect, and we have to ask the patient to put second drop after 5 minutes only, so that the washout period is over and one drop will not overlap other and will not decrease the effect of other. Non-compliance is a major factor which we have to take into account in a chronic condition, because the patient is going to put that throughout his life, and compliance can be improved mainly by the counseling of the patient. So to conclude, the lowering intraocular pressure remains the only treatment strategy. Now we have only got IOP lowering agents which are going to help medically in glaucoma. It is the only approach proven to halt or delay progression. Ideally start with monotherapy, add or switch when needed, like I told. And PG analog is the now golden standard of treatment. Previously it was temolol maleate. And the development of the newer drugs like natarsudil, which function on the trabecular meshwork, which is the cause of all the defect, it is better now. The future looks very bright, and we can continue with the medical treatment. Thank you for participating. Now we'll be covering the surgical management. After that, we'll discuss any question on the treatment of glaucoma. Next, Dr. Padma Malini.
After medical management, now we'll be shifting to the key points in surgical management of glaucoma. So when do you do surgical management? When there is glaucoma progression on medical and laser therapy, that is maximal tolerated medical therapy, that is more than 3 classes of medical drugs are not enough to control the intraocular pressure. Also in advanced glaucoma with high IOP on presentation, low target IOP is desired, that is family history of glaucoma or normal tension glaucoma. When there is poor compliance, adherence, or if there are socio-economic problems. So we have surgeries to improve outflow, that is penetrating glaucoma surgery. Then we have non-penetrating glaucoma surgeries. We have minimally invasive glaucoma surgery, angle surgeries. We have glaucoma drainage devices, and then we have surgeries to reduce inflow. So we have lot of surgeries in the glaucoma to reduce intraocular pressure. So how to make a decision? It depends on the safety and efficacy of the procedure. Also, it depends upon the glaucoma disease spectrum. As Madam told you that we have now 3 groups, that is mild, moderate and severe glaucoma. If it is a mild glaucoma, the target is between 15 to 17 mm of Hg, and we can have medical therapy, we can have laser trabeculoplasty, or we can have cataract extraction, especially in cases of narrow angle glaucoma. If the disease is moderate, then the target is between 12 to 15 mmHg, and we can have mixed procedures for these type of glaucomas, that is mild to moderate glaucoma, along with cataract extraction. If the disease is moderate to severe, then we can have trabeculectomy with mitomycin C. We can have trabeculectomy with cataract extraction. And if the disease is severe, then we can have tube shunt surgery or endocyclophotocoagulation. So depending upon which severity of glaucoma, we can choose a procedure. What are the pre-operative assessment? So we now are shifting our focus to the gold standard, that is trabeculectomy. So pre-operative assessment include good history and examination, which is very crucial for any glaucoma procedure. Identify high-risk cases for bleb failure, that is young age, myopia, previous trabeculectomies which were done, ocular surface disease, and also if there are blepharitis. You have to treat them before taking patient for glaucoma surgery. Identify areas of immobile conjunctiva with Q-tip, and that is how you can plan the filter position. Look for active inflammation in anterior chamber, that is AC cells, and you have to treat uveitis before taking patient for trabeculectomy. Vitreous in AC, also lens status. Do fundus evaluation and gonioscopy of both eyes, which is very important. Don't just treat one eye. Do gonioscopy of both eyes. Pre-operative preparation include written consent, and for glaucoma it is very important to tell patient that this surgery is not for improving vision like cataract extraction. This is to maintain vision, and here vision may drop by one line after surgery. Also tell patient may need anti-glaucoma medication in post-operative period. There may be need for repeat surgery. Continue systemic medication, as most of the patients have systemic problems like diabetes, hypertension. You can stop oral anticoagulants after consulting physician. Start topical antibiotics and steroids. Give preoperative IV mannitol to avoid suprachoroidal hemorrhage on table, especially in cases of narrow angle glaucoma. Avoid excessive ocular compression while giving the massage after anesthesia, because the optic nerves are very fragile in these patients. Anesthesia can be peribulbar block, topical, subtenance, intracameral, and GA, especially in congenital glaucoma. So we have Moorfield Safe Surgery System trabeculectomy, which is an evidence-based step-by-step approach to trabeculectomy, which is given by Sir Peng Kaw, and it tells us how to do trabeculectomy to avoid post-operative complication. And it tells us for diffuse and posterior wide application of mitomycin C to avoid ring of steel. You can see the ring of steel which was there before this technique came into picture. Then the sides of scleral flap are kept intact to maximize the posterior flow of aqueous. The conjunctival closure by this technique is by Weiss technique. So the surgical success rate of trabeculectomy is very good. That is more than 75% in cases of primary open angle glaucoma, angle closure glaucoma, exfoliative glaucoma, pigmentary glaucoma, and also angle recession. But it is not so good in neovascular uveitic congenital and when there are two failed filter surgeries. So today I'm going to speak about how to combine mitomycin C augmented trabeculectomy along with small incision cataract surgery. As you all are doing small incision cataract surgery, it is very easy to combine trabeculectomy along with SICS, and everybody can do this combined procedure very easily. So under peribulbar block, superior rectus traction suture is taken, a phonics-based conjunctival flap is created, and this is a small incision cataract scleral tunnel, and then 3 mitomycin C soaked sponges are applied below the conjunctiva, keeping the edge of the conjunctiva away from the mitomycin C. After 2 to 3 minutes, the sponges are removed from the subconjunctival area, and the area is washed with 20 cc of BSS or ringer lactate. So thoroughly wash the area of mitomycin. From the side port, the air bubble is injected, and this is again a routine SICS which you are all doing. Inject viscoelastic, perform the Rexis as you are doing for SICS. Then enlarge the lip of the main incision with keratome. Remove the nucleus with sandwich technique or whatever you are comfortable with, and do cortex wash. After that, insert a single piece 5.5 mm PMMA PCIOL in the bag as you are doing. So this is just manual small incision cataract surgery with PCIOL, as you all are well versed with. After that, you have to do trabeculectomy. It is advisable to take pre-placed suture, take Kelly sponge and make internal ostium. It could be 0.5 mm. Then do iridectomy through by Vanna's Caesar and wash it. After that, you have to suture the scleral flap, which can be done by 10-0 nylon using 4 suture loops. And you can take 2 or more sutures like this to cover the scleral flap. And you can also have 1 or more interrupted suture on this. Put the trypan blue dye to see for minimal spontaneous filtration. So here that is what is done. And in the end, conjunctiva and tenons is closed by 8-0 Vicryl in a watertight manner, taking some bites at the limbus to anchor the conjunctiva on the limbus. That way you can achieve a very watertight closure of the conjunctiva at the limbus. So this is all about the conjunctival closure, which we call as the conjunctiva is princess for the trabeculectomy surgery. We have to and in the end, BSS is injected in the AC to form the diffuse conjunctival bleb. So this is a very simple procedure to combine the trabeculectomy with the SICS. Postoperative care is with steroids, antibiotics, cycloplegics, and anti-glaucoma drugs if needed. So considering infrastructure, resources, doubtful follow-up visits, non-compliant patient, and advanced glaucoma which is detected along with cataract, I think trabeculectomy with SICS is a simple and economical solution which has minimal post-operative complication. You can also do phacotrabeculectomy, which can be one side, two side, whatever is, both the techniques are fine. But you can also do this technique very easily, combining the trabeculectomy with mitomycin C along with SICS. Thank you.
Thank you, Dr. Rekha, for such a nice presentation and nice videos you have got. The next speaker, any doubt in the glaucoma? Then we'll have to next speaker is Padma Malini.
Ma'am and dear friends, very good afternoon to all of you. At the outset, I'd like to thank Dr. Santosh Onavar and AOS team for inviting me here today to speak to your key points in the management of uveitis. Slides are not moving. Yeah. We follow the stepwise approach in the management of uveitis. That is, as soon as when the patient walks in, we observe them, and that itself will give a clue what are the associated systemic disease the patient might have. First, detailed ocular history, then complete ophthalmic evaluation, which includes dilated fundus examination with scleral indentation. Then systemic evaluation. We'll do a naming and meshing. Accordingly, we order relevant investigations and start the patient on appropriate management. If the patient is refractory to treatment or not responding to the treatment, we'll re-investigate again and change our treatment plan. So this is the way we work on it. What are the algorithms is available? Broadly, we divide the uveitis into infectious or non-infectious uveitis. From our, it's important that we need to treat infectious uveitis with appropriate antimicrobial therapy. If it has a bacterial infection, we treat them with antibacterial agents. The commonly one is ocular tuberculosis, we treat them with anti-tuberculosis therapy, 9 months course commonly we follow. Or if you have a syphilis, we treat them with anti-syphilitic treatment. Next comes the viral. If it could be due to herpetic viruses, in that we treat them with acyclovir. It could be in the form of topical or systemic therapy. If it's CMV, we treat them with ganciclovir, intravitreal or systemic ganciclovir therapy. If it's antifungal, fluconazole, itraconazole or other antifungal agents including amphotericin B in severe candidiasis. Next, antiparasitic albendazole is also used. More importantly, in infective uveitis, in addition to anti-infective therapy, we also treat them with anti-inflammatory such as corticosteroids to control the eye inflammation in majority of the infective uveitis. Next, we'll move on to non-infective uveitis. Coming to the non-infective uveitis, the corticosteroids is the gold standard in controlling the inflammation. It could be in the form of topical or systemic, periocular or intravitreal steroid implants. In the systemic, it could be in the form of oral or intravenous methylprednisolone we give. Next comes immunosuppressive. In the immunosuppressive therapy, commonly we use the drugs are methotrexate, azathioprine, mycophenolate meftil, or T-cell inhibitors like cyclosporine, cyclophosphamide, and tacrolimus can be used. Next comes the recent drugs such as biologics. In this, we use infliximab, adalimumab, etanercept, or rituximab. Depending upon whether it's T-cell mediated disease or B-cell mediated disease, we choose the appropriate biologic agents. The recent drugs are Janus kinase inhibitors. Drugs like tafasitamab and baricitinib are also used to control the inflammation. The next is role of periocular steroid injection. Here, commonly what we use is the Smith-Nozick technique or orbital floor injection. Here, the periocular injections to be avoided in a case of an infective uveitis, especially conditions like toxoplasmosis or necrotizing retinitis. Next is viral uveitis. Viral, we diagnose based on the clinical presentation. Can have diffuse pigmented keratic precipitates across the cornea or atrophic patches of the iris with increased intraocular pressure. We make the diagnosis based on the clinical presentations and treat them on appropriate antiviral and anti-inflammatory therapy. Coming to the posterior segment manifestation, this is an emergency. You have to dilate and see in the fundus, otherwise many times you may miss acute retinal necrosis, what is happening in the retinal periphery. ARN is called Swiss cheese pattern. CMV retinitis, what we call it as a pizza pie appearance or tomato ketchup appearance. PORN is a cracked mud appearance. So we make the diagnosis based on the clinical presentation and start the appropriate antiviral therapy at the earliest without waiting for the lab investigations, especially in necrotizing viral retinitis. Corticosteroids should never be started without appropriate antiviral cover in these entities. The next we'll move on to toxoplasmosis. Toxoplasmosis is the commonest cause of infectious posterior uveitis across the globe. And they have classical presentations like headlight and the fog appearance. These lesions can occur adjacent to the previous scar or somewhere in the fundus. We make the serological diagnosis IgG and IgM, or in apical presentations, molecular diagnostic like this B1 gene for toxoplasmosis is useful. In this entity, we start the patient on anti-toxo treatment followed by systemic steroids. 4 weeks we'll give, and depending upon the response, we stop the systemic steroids and anti-toxo treatment to be continued. The next we'll move on to tuberculosis. Tuberculosis have granulomatous panuveitis. What we commonly see is a retinal vasculitis. Here we could see a scar along the vessels could be one of the clinical clue to pick up tuberculous vasculitis and also differentiate it from sarcoidosis. Anterior segment, they can have broad-based posterior synechiae. They have peripheral vasculitis, and FFA is important to map out the areas of capillary non-perfusion. We treat them with ATT, systemic steroids, and laser photocoagulation if there is a capillary non-perfusion areas in the retinal periphery. We order MANTO, chest X-ray or HRCT. HRCT is more sensitive, and quantiferon TB gold test. If we have a lymph nodes, we can do the biopsy. From the ocular fluid, we can do a PCR for tuberculosis, that is MPB64 or IS61110. Here, Based on that, we can have a confirmed diagnosis or presumptive diagnosis. Recently, COTS calculator is available. In that, if we feed the data, it gives us the possibility of the tuberculosis. Most of the times it is presumptive, so that we can convince the physician to start the patient on anti-TB drugs. Next, we'll move on to syphilis. Syphilis is a sexually transmitted disease. It has a great masquerade. It can mimic any type of uveitis. You can put them in the differential diagnosis. In common, classically, the posterior ones are placoid chorioretinitis or triangular patch of retinitis or punctate inner retinitis. These three, whenever we see this particular pattern, we need to suspect syphilis. We order both non-specific and specific tests for syphilis, that is TPHA or FTABS in specific, or VDRL or RPR. After making the diagnosis, we have to start them on systemic antisyphilitic treatment with penicillin. The next is, what are the things we need to rule out the differentials? Here, uveitis can mimic other uveitic entities like masquerades. That is uveitis in extremes of age group, retinoblastoma in children and masquerades in older age group, or posterior scleritis. Here the patients will complaining of severe pain, excruciating pain. It wakes them up from the sleep, and they can have classical, what we call it as a subtenon's fluid or T sign. Based on that, we make the diagnosis of posterior scleritis. Next, other entity is multiple cotton wool spots in the fundus, could be secondary to systemic diseases like hypertension, or if we have multifocal CSCR, it is important to differentiate from other exudative detachments like VKH, because if you start steroids, the patient is going to worsen. In uveitis, the corticosteroids is the treatment of choice. In CSCR, we tend to avoid corticosteroid therapy. Coming to the take-home message, in uveitis, we need to do the detailed history, complete ocular examination, that is dilated fundus examination with scleral indentation, and we have to pick up the clues, both ocular as well as based on the systemic examination. If you are not sure, better not to start the patient on oral steroids, and we have to avoid inappropriate and inadequate therapy. And also we have to watch out for development of complications like cystoid macular edema, choroidal neovascular membrane in uveitis. So once we recognize the complications, we need to address the complication, and we have to pick up masquerade syndromes because the management is going to be different than the uveitic entities. Thank you for your attention. Any questions, I'll be happy to take them.
Thank you, madam. Very nice presentation. Any questions from the audience?
Yeah. Wishing you all the best. Thank you.
Next, I think Dr. Norris will have to present. He's going to present on endophthalmitis.
Check. Slides ready? Yeah. So, I don't know, we are in 12, okay, 12:20. So, I'll say good afternoon. So, how many of you are PGs? Excuse me, you both are not PGs? You? No, okay. No, the reason for asking is I know it's so difficult actually, because it's so difficult to come to the first session of the first day or the second day. When you're so patiently sitting for the last session, it's so nice to see. So just to keep all of us awake, there will be few questions, right, in between the slides. You just answer to yourself and you find out how many are correct at the end. Okay, it's not to test anybody's knowledge, just to keep us, slides are not moving, sir. Slides are not moving. Yeah. Okay. So this is the basic definition of endophthalmitis. So it's basically the inflammation of the inner layers of the eye, and there will be exudation. In the vitreous cavity, it can, due to the colonization of the organisms. Okay, sometimes toxins can also lead to this, but that we call it as TAS. We'll just discuss that. So it can be endogenous or exogenous, but we'll be discussing only about the post-op endophthalmitis. Okay, we'll not be discussing. So this is the first question. What do you think? Which of the following is not a conjunctival commensal? Just answer to yourself, okay? Just to keep us awake. We'll move on. So you'll get the answers for this. So by definition, we have got basically an acute or chronic or a delayed endophthalmitis based on less than 6 weeks or more than 6 weeks or further delayed. Okay, so accordingly, you can brand it as a acute or chronic. So this is a question number 2. Which of the following statement is false? You just go through. Just answer to yourself, okay? You just see how many are correct at the end of this. So basically, the incidence of post-op endophthalmitis varies, and it is as low as 0.009. And in fact, in only 1 year in SNEC Singapore, when they operated close to 55,000, they had only 1 year of zero endophthalmitis year. And subsequently, they also had, and they say the rate of infection is no different if you do a bilateral cataract surgery. Even if it's a bilateral cataract surgery, it's the same. So what is the common organism in post-op cataract surgery? Okay, you just see one of them will be the right answer. You just note. Okay, the common organisms, especially in case of acute onset post-operative, it will be a coagulase negative staphylococcus. Okay, in case of a blood-related, it can be Haemophilus or the Streptococcus species, and in case of a delayed, usually it is Propionibacterium. Okay, usually you'll be having a recurrent waxing and waning of the disease in such cases. And in case of post-trauma, Bacillus is common. The severity of the disease basically depends on the virulence of the infecting agent, especially with the gram-negative like Pseudomonas, but it will be very violent. You can lose the eye within 24 hours also. And the amount of inoculum of the infecting agent and the time you diagnose, the more you delay, and of course the immune status of the patient. This is a question number 4. Just see the factors responsible for the endophthalmitis include all. What could be the exception in this? Okay, just answer. So the sources can be one of the 4. It can be from the patient or from the instrument or the personal or the environment. Okay, so patient's own flora we come across very commonly, and it can be eradicated, or you can avoid that by using a povidone iodine. And this is the only drug which has got a level 1 evidence in the prevention of endophthalmitis. So povidone iodine is a must actually. The other sources can be the contaminated surgical instruments or the surgical environment. And usually these cause cluster endophthalmitis, okay? The risk factor is a PCR. Whenever there is a PC rent, the chances are very high. And if the patient has got a PC rent, please do an indirect ophthalmoscopy next day with a dilated pupil, because sometimes there will be a dropped cortex, and that dropped cortex can lead to inflammation which will mimic like a endophthalmitis. So many times we have come across the lens matter induced uveitis as a differential diagnosis. Okay, so this is about the onset. Most of the time it happens between 4 and 7 days, right? Very rarely after 6 weeks. Okay, so all of these are suggestive of endophthalmitis, except what could be the thing? Just see, we'll go further. So the commonest symptom will be vision drop, whether it is ESCRS study or in the EVS. And you can have pain in close to 75 to 80% of the cases. You can have redness, swollen eyes, and the media is hazy in almost 60 to 80% of the cases in those 2 studies. And anti-segment, usually the pupillary reaction will be very sluggish or it is absent. A mobile pupil is always a good prognostic sign in case of endophthalmitis, and the lens may be covered with a membrane, and you can see the exudates around the IOL. Like this, you can come across. And posterior segment findings, initially there can be vitritis with exudates. The red reflex may be absent, the fundus view will be obscured, there can be papillitis, and depending upon the organisms, you can have retinal hemorrhages and peripheral vitis also. So when you do a B scan in endophthalmitis, you can find all these findings. What could be the exception? Okay. So you do an ultrasound, the basic thing you will be looking for is the exudates. So it is also point source opacity. unlike vitreous hemorrhage, because of the gravity, it is more denser in the inferior area. In case of endophthalmitis, you will come across the opacities uniformly inside the vitreous cavity, number 1. And number 2, the RCS complex thickness is 1 millimeter, which will be thicker in these cases. And later on, when the fluid collects, when the patient goes in for panophthalmitis, we can have subtenon fluid collection, including T sign, or you can have a choroidal detachment and the retinal detachment also. So the basic thing is, you'll have point source opacities in the vitreous cavity with a thickened RCS. Okay, so additional assessment you have to make is, you have to assess whether it's a sterile endophthalmitis or the other reasons. The nutritional status of the patient has to be assessed, and of course the systemic assessment of the patient. So one of the differential diagnoses for endophthalmitis is TAS. So what could be the exception? I'll tell you, in case of TAS, usually it occurs within 24 hours, and most of the endophthalmitis usually happens after 24 hours. Most common thing is when you come across a limbus to limbus edema in the cornea, it is TAS. And third thing is the pupil will be dilated and fixed. And fourth thing is the IOP will be very high in case of TAS. And in case of vitreous exudates, most of the exudates will be limited to the anterior vitreous. Posterior vitreous usually will be clear. And usually this condition is very well treated by the steroids, and if you use anti-glaucoma medication, most of the time it becomes all right. Okay, it is because of the toxins and the poor sterilization thing. So this is one of the case of TAS treated only with the steroids, no antibiotic, and over a period of time it cleared completely. Okay, so these are the reasons why you get TAS. It can happen right from the irrigating solution to the viscoelastics to the ophthalmic instruments and the ocular media. Okay, so whenever there is a TAS happens, usually it doesn't happen in isolation. It happens in cluster. You assess what's happening. Okay, so these are the differentials between the TAS and endophthalmitis. And the complications of TAS can be severe inflammation, pain, and vision loss because of raised IOP and the corneal changes. The iris can be atrophied and the pupil will be irregular. And damage to the trabecular meshwork can lead to a permanent raised IOP. Okay, so these are the reasons why the patient will lose vision because of TAS. That is due to the permanent corneal endothelial decompensation, intractable glaucoma, and cystoid macular edema. So just for want of time, we'll just directly go to the management. Management usually, you just answer this. So in case of sample collection in endophthalmitis, what could be the false response in this? Okay, I think you have read. So basically we follow EBS, but many things have changed from the days of EBS. All you have to do, when you come across an endophthalmitis, straight away go and treat. It's not a rocket science. Every ophthalmologist can treat endophthalmitis. All you have to do is vitreous tap with intravitreal antibiotic. Empirically, what we give is vancomycin, ceftazidime, and if you are very sure that it's not a fungal infection, we can go for steroid also. Okay. Regarding the treatment and the antibiotic, just what would be the wrong answer? So usually we go for 1 milligram of vancomycin in 0.1 ml or 2.25 milligram of ceftazidime. And if you're using voriconazole, you can use 50 to 100 microgram. And vancomycin is a very safe drug. Even you can inject up to 6 millimeter without causing any retinal damage. We inject only 1. In case of gram negative, we can go for amikacin. Initially, we are injecting 400 microgram. Now it is 250. Then it is further reduced to 150 microgram because to avoid the retinal toxicity. And for prophylaxis, I'll just conclude with this. Prophylaxis, you have got two things. In EACRS, we have been using ceforaxime, but now in our last series from our institute, we use what we call moxifloxacin as a prophylaxis, and it has considerably reduced the post-op endophthalmitis. You can go through that. We have a very large series of 1 million surgeries done with this prophylaxis. It really helps. And another thing is, even if the endophthalmitis happens in these cases, we don't come across any what we call culture positivity, and the inflammation or the infection is also very less. So with that, actually endophthalmitis treatment is not a rocket science. Any ophthalmologist who operates can treat it. And just one thing, without any financial interest, there is something called e-kit in Orolab, which has got this vancomycin, ceftazidime, and oriconazole with all the kits and the injections, and with a single dilution procedure. You just inject 10 ml, 10 ml and take 0.1 ml and inject inside the eye, because otherwise we'll have to do some calculation when you are reconstituting the injections. Okay, with that I would like to conclude. Any doubts we can ask, otherwise thank you very much.
Dr. Natasha. This one.
Next talk is on vascular occlusions. Ma'am, you're speaking on vascular occlusions?
Yes, yes.
Okay. After that, admission.
Thank you. At least someone to say my name. Hello, everyone. And happy to be here today to give you a few points on retinal vascular occlusions. But retinal vascular occlusions is a very, very vast topic. So to finish it in 10 minutes is like next to impossible, but I'll try to do justice, at least tell you some of the salient points. Okay. So you can have arterial occlusions, you can have venous occlusions, you can have combined occlusions. The arterial occlusions, central retinal, branch retinal, cilio-retinal artery, and the ophthalmic artery occlusions. We'll go to venous occlusions first. They can present as an acute defective vision. They can present as an incidental diagnosis. Sometimes when you're working up the patient for cataract and you're looking inside, you might find a sheathed blood vessel, because if it doesn't involve the macula in a branch vein occlusion, it will not be symptomatic. And sometimes it presents with complications. You're seeing traction retinal detachment in one quadrant, or a vitreous hemorrhage in in a patient, and it may be an old branch vein occlusion which was missed, and then the sequelae occurred. So here you can see there is an infratemporal branch vein occlusion on this side and a CR, central retinal vein occlusion, on the other side. You know that the central retinal vein occlusion is called a splash tomato ketchup appearance because of the large number of hemorrhages. Now, the most important thing when you see a vein occlusion is to do the risk identification. The most important thing I look at when the patient comes to me with a vein occlusion, the first thing that you should look at is what is the age of the patient, what are the metabolic diseases that the patient has, and atherosclerosis, hypertension are the major risk factors. When you're looking at other causes, hypercoagulable states, occlusive periphlebitis, local factors, you should look for glaucoma, any evidence of inflammation. Now, how do you how do you proceed? So if your patient is older than 50 years, then you have to look for systemic risk factors like hypertension and diabetes. They may be already having, in which case you already have your culprit there. If they do not have that, if they don't have hypertension and diabetes, send to a physician for a workup for hypertension or diabetes or dyslipidemias, which are the common causes. Now, if the patient is less than 50 years, you have to treat it like you would treat a young stroke. So all the causes for vein occlusions in a patient who is younger than 50 years is the same list that you have for young stroke. So you have to look at what are the risk factors you will look for. You need to look for hematological risk factors, which are the coagulopathies, and you need to look for the inflammatory risk factors, which are the what we call broadly the collagen vascular diseases. So hematological diseases, you have to look for your protein C, protein S, antithrombin 3, Leydig, factor 5 Leydig. The whole gambit has been done, including peripheral smear for workup for coagulopathies. For inflammatory, the ANA, ANCA, serum ACE, HLA profile, all of that depending on the systemic features that the patient has with the help of a rheumatologist. The occlusive vasculitis causing a venous occlusion, fundus examination will give you a clue which we will look into later. So just remember one thing. First thing, venous occlusions are almost always thrombotic. They are not embolic. So we are looking for causes of thrombus. And causes for thrombus in an older age group is usually hypertension, diabetes. In a younger age group, we have to look at both coagulopathies and inflammatory causes. So that is the main thing that you have to keep in mind. Now, your clinical examination should include your slit lamp examination to look for neovascularization. If it's an old venous occlusion, you should look at the fundus for what are the quadrants that are involved, what is the macular edema, and any signs of the sequelae. And you're also looking for clinical signs of the etiology, whether you're looking at vasculitis or not. When it is a central retinal vein occlusion, it's very important to differentiate ischemic from non-ischemic. Now, what is the importance of differentiating? The most important is about prognostication. So ischemic CRVOs will have much less visual acuity and much bad prognosis compared to your non-ischemic CRVOs. What are the clues? First thing is visual acuity. Very poor visual acuity, like you're looking at less than 6/60, more likely to be ischemic. Second thing is RAPD. Presence of RAPD, it is an ischemic central retinal vein occlusion. Third thing they say is fields, but when the visual acuity is so low, we usually do not do the fields. But if you are in doubt, if you have a visual acuity of 636, 618, you can do a visual field. Visual field mostly affected in ischemic, will not be affected in non-ischemic. The clinching diagnostic feature is your fluorescein angiogram, which will give you more than 10 disc diameters of non-perfusion areas, then you're looking at ischemic. Less than 10 DD, then it is non-ischemic. And of course, the ERG with the B/A ratio not being affected is also non-ischemic. But ERG, of course, is only for research. We don't really do it. Like I said, clues to the etiology, you can look for evidence of vasculitis. So you're looking for disc edema, you're looking for vasculitis in other quadrants, then you are thinking of one of the inflammatory pathologies and not just, and then you also have to ask a proper history about any systemic causes. Now, what are we going to do? For central retinal vein occlusion, once you have differentiated between ischemic and non-ischemic clinically, you have to do an OCT to look at the macular edema. The fluorescein angiogram, if you are doubtful if it is ischemic or non-ischemic. Fluorescein angiogram advised by the CVOS study is to do it after some time once the hemorrhages are resolved, but you should remember that the CVOS study was done in the pre-anti-VEGF era. So now we don't really wait for 3 months for the hemorrhages to resolve and then do a fluorescein. You can still do the fluorescein and you can differentiate the blocked fluorescence from the CNP areas. The rationale was that because of the blocked fluorescence, you cannot pick up the CNP areas, but because of our newer imaging techniques, we can actually see the CNP areas even if there is some amount of blocked fluorescence due to the hemorrhages. So you do that and then your risk stratification becomes much easier, prognostication becomes easier once you do the fluorescein angiogram. For macular edema in venous occlusion, we inject. First choice is usually anti-VEGF, and if the patient has some risk factor for anti-VEGF, you can consider implantable steroid like dexamethasone, Ozurdex. If the patient is pseudo-phakic, cannot come for follow-up, again you can think of an implantable steroid. In ischemic CRVO, even if there is macular edema, it may become flat after injection, but vision may not improve, and that should be very clearly explained to the patient. In ischemic if non-ischemic CRVO, you're just going to inject till the macular edema resolves, keep the patient on follow-up for something called ischemic conversion. Non-ischemic can convert to ischemic as the disease progresses. So you have to keep the patient on follow-up monthly for the first 6 months, 2 monthly for the first year, and then 3 monthly for the next year. If the patient has ischemic CRVO, once you have treated the macular edema, we do prophylactic pan-retinal photocoagulation because our patients will not come for follow-up. The recommended schedule is monthly follow-up, looking for neovascularization of the angle and the iris. Once you have more than 180-degree NVA or NVI, then you do PRP. That was the CVOS recommendation, but we generally don't follow that. If you have ischemic CRVO, you do a prophylactic PRP. So you prevent the neovascularization. Of course, vision may not improve, which has to be very clearly explained. So that was CRVO. BRVO, you inject for the macular edema. Modified grid laser was recommended by the BVOS, but we don't follow it anymore because the anti-VEGFs give a better treatment response. Now, yeah, I knew I won't have time.
Okay. Arterial occlusions. Arterial occlusions as compared to the venous occlusions are 99% embolic. Okay. Except when you have vasculitic, when you have arteritis, polyarteritis nodosa or giant cell arteritis that is causing the arterial occlusion. Otherwise, most of the time they're embolic. So your primary responsibility as an ophthalmologist is to find the source of the embolus. Treatment, we don't have much to offer them, especially if they come after. What is the retinal downtime? Retinal ischemic time? 90 minutes. 90 minutes. So you have to treat, if you want to get good response in central retinal artery occlusion, you have to treat within 90 minutes, which none of our patients will reach on time. So most of the time we have nothing to offer in the way of treatment, but you can save the life of the patient if you investigate for the source of the embolus. The two important investigations that you have to do, echocardiography to look for any calcification, any vegetations in the valves, and any other thrombus, mural thrombus, etc. And a full cardiology evaluation, and carotid Doppler to look for the thrombus in the carotid arteries, which is the next common cause. So those two investigations you have to do. What can you offer in terms of, next slide please. Time up, is it? Yeah, what can you offer in terms of treatment? You can do quickly do ocular massage, which is just increasing the intraocular pressure, reducing so that the clot gets dislodged. Or you can do a paracentesis in your OPD or in the OT to suddenly reduce the intraocular pressure and allow the blood to gush through and remove the embolus from the central retinal artery. Now, those are the two things that you can quickly do. A lot of other things have been tried, but none have been very effective. Then, let's say, ciliaretinal artery is not so important. How will you differentiate ophthalmic artery occlusion from central retinal artery occlusion? I will stop with that. Ophthalmic artery occlusion from a central retinal artery. One, vision will be no PL. No PL vision in a central retinal artery occlusion. What you think is central retinal artery, always remember it's probably ophthalmic artery. Second thing is the cherry red spot will not be very evident. There will be diffuse whitening of the retina, but the cherry red spot will not be seen because choroid is also ischemic. Okay, those two things can help you differentiate. We will stop with that. Thank you so much.
Thank you, ma'am. Now I request Dr. Sanjay Kumar Mishra to deliver. Actually, you want to present that? Yeah. Anushra, take.
So I am Anashwa. I am greetings from LV Prasad Eye Institute. So I am an ophthalmic plastic surgeon and an ocular oncologist. So while he's uploading the presentation, I have a question for all of you. So when you see a patient with an eyelid nodule in your clinic, what is the next thing you will do to him? So you see a well-defined nodule on the eyelid. What next? Anyone? You have some time to think. Two patients. So you have inspected, you have palpated. What is the next thing you will do to understand that one thing, whether it is benign or malignant? Very good. So eversion of eyelid you need to do. So what do you see in the first picture? The first picture is of a 15-year-old boy, whereas the next picture is of a 62-year-old gentleman. So what do you feel? Which one is benign, which one is malignant? Why so?
फिर मैं नहीं प्रेजेंट करूँगा, मेरा हो गया ना. हाँ? कोई वैल्यू तो है नहीं.
Distorted margin. So what you just said, so you see the lid margin, the contour is not even. In the right eye, it is little away from the lid margin, well defined. circular. There it is not that well defined and the lid margin is distorted. Okay, so now we evert. So this is what you see. So the very first point that I want to drive today is that beware of the red flag signs. So the first thing what you need to understand in your OPD is it benign or malignant? So what are the red flag signs? So what do you see here? So it is a yellowish, irregular eyelid nodule, distorted eyelid contour, effacement of the meibomian gland orifices. There is loss of lashes, which is extremely important. There is surface telangiectasia there. The yellow thing, there is fluorescein just staining it. So there is also surface ulceration and crusting. So all these are signs of malignancy. So you also see a bilamellar involvement, which was extremely well visible in the first picture that I showed you. So whenever a patient with an eyelid nodule walks into your clinic, you will have to evert the eyelid and look for all these signs along with the bilamellar involvement. So sebaceous gland carcinoma, what we most commonly see in our OPD. So whereas in contrast to those two patients, here there is no lash loss, or in other words, the red flag signs are not there. So they are all benign lesion. So why is it important for us to, now you have done the first step, you have understood whether it is benign or malignant. Now why is it important for us to know that? Anyone? How will it affect our management? So how much margin to take is the next question. So if it is a benign lesion, yeah, so if it is a benign lesion, we just remove it in toto. That suffices. Whereas if it is a malignant lesion, we will have to perform a wide margin excision. So by what do I mean by wide margin excision? From the clinically apparent tumor, we take 4 millimeter margin like this. And many a times for sebaceous gland carcinoma, what we see is key on the posterior lamella or on the conjunctival side, the involvement is more. So we do a differential excision, like it is less on the anterior lamella and more on the posterior lamella. But what is important is you will have to take wide margin on both the sides. Okay, so wide margin excision is what we do when we are we see the red flag sign, and if you are in dilemma, like you don't understand, there are some features of malignancy, some not. So then you can even go ahead and perform an incision biopsy, establish your diagnosis, and then go ahead with a wide margin excision. Okay, so the next important thing, so this is differential excision, what I am showing. On the posterior aspect, the involvement is more. Next slide. So then the margin control, here I am taking the 1 millimeter of extra margin for sending for frozen section. If you don't have a frozen section set up, you can also wait for the histopathology section report to come and then perform the reconstruction. But margin clearance is extremely important. You need to have either a frozen section or a histopathology report that the margins are negative of tumor. Then only you should go ahead and do an eyelid reconstruction. Okay, so moving on to the pagetoid spread. What is a pagetoid spread? It is an intraepithelial spread of sebaceous gland carcinoma away from the main tumor. So earlier what we used to do was we used to look into the clinical pointers. These are all clinical pointers of pagetoid spread. Diffuse conjunctival congestion, diffuse thickening of eyelid, loss of meibomian architecture, loss of eyelashes, surface telangiectasia, all these features away from the main tumor, we used to suspect pagetoid spread and do a map biopsy. But recent evidence suggests, you can see this paper from our institute, which says that 10% of cases of pagetoid spread will be missed if you only go by the clinical criteria. So, and if you see here, the metastasis and death rates are remarkably more if there is a pachytoid spread. So what we recommend is that MAP biopsy should be performed in all cases of periocular sebaceous gland carcinoma. This is the evolving literature, and what we do is a 17-site MAP biopsy. So from these particular locations, we take small pieces of conjunctiva and send for a histopathology examination. Next slide. The next pearl that I want to tell you is about the multimodal treatment for advanced tumors. So earlier, for the advanced tumors, we only had options of, whenever there was an orbital extension, we only had option of orbital exenteration. But that is no more the case. There is enough literature to suggest, and it is a, so if you see here, this particular patient is a sebaceous gland carcinoma patient. If you see the corresponding CT scan, so one rule of thumb is, whenever for a patient you don't see the posterior extent of a lesion, you should go ahead and do a CT or MRI. So for all cases of oculoplasty, when to do a orbital imaging? When you can't see the posterior extent of the lesion. So in this case, we couldn't palpate the posterior extent of the lesion. We went ahead and did a CT scan, and you can see that there is a superotemporal orbital component. Okay, so earlier days we used to do exenteration for these patients, but now there is a fairly established chemotherapy protocol for this group of patients. We use cisplatin 5-fluorouracil. So this is a neoadjuvant chemotherapy, a chemotherapy which is given before the surgery is a neoadjuvant chemotherapy. So we give neoadjuvant chemotherapy. You can see the tumor has shrunken, and there we can do a globe salvage surgery. So exenteration won't be required for this patient. Only a excision biopsy will suffice. So the next pearl is chemo reduction happens in, this is more valid for sebaceous gland carcinoma and also squamous cell carcinoma, not for basal cell carcinoma. The next thing is, you need to look for regional lymph node. You need to palpate for the regional lymph node at your level. Knowing the drainage of the eye is extremely important. You need to palpate for the preauricular, postauricular, anterior cervical, posterior cervical, and the submental lymph node in all patients where you suspect malignancy to understand the regional spread. Next slide. So we also need to know about sentinel lymph node biopsy to understand. So before the lymph nodes become palpable, to understand micrometastasis, sentinel lymph node biopsy is a good technique, but it is done in very few institutes. But you need to know about it. So till now, let us just recapitulate what we have learned. So a patient with eyelid tumor walks into your clinic, you will have to first differentiate whether it is benign or malignant. You have seen the red flag sign, it is malignant. You have gone ahead with a wide excision biopsy with margin control, margin cryo. Now you will have to see the biopsy report. That is also extremely important. The management doesn't stop with the surgery. So what is the post-operative protocol? So we look for the histopathological known risk factors. Like, was there any perineural spread? Was there any intraneural invasion? Was there any vascular emboli? These are all high-risk features. Whenever it is there, post-operative, we prefer giving an external beam radiotherapy. Next is if there is a fixed frozen mismatch. So that is also literature says 2% of patients can have a fixed frozen mismatch. So fixed frozen mismatch means that on table I had sent for frozen section. My pathologist has told me ki everything is clear. I have gone ahead with an excision biopsy and reconstruction. And then when the histopathology report the fixed sections comes after 1 week, I see there is involvement of the margins. So what do we do then? So if there is a fixed frozen mismatch, if it is a lamellar, we can go ahead and do a cryotherapy. If it is full thickness, we will have to send the patient for EBRT. So for MAP biopsy, we do MAP biopsy, I just mentioned, for all cases of SGC. So if the MAP biopsy is positive, we need to see whether it is localized positivity. They will tell you that 0.3 is positive, 0.4 is positive. If it is a localized positivity, you can just go ahead and do a cryotherapy. Mitomycin C topical therapy is also something which has been described in literature. But if it is a diffuse positivity, multiple areas involved, then exenteration is the best treatment for these group of patients. Regional lymph node metastasis, if it is there, radical node dissection along with radiotherapy you will have to do. So this post-operative protocol is also important. It is not only about identifying it as malignant and doing an excision. This is which will decrease your rates of recurrence. The ninth point which I wanted to stress is not all malignant tumors we will excise. Next slide. So this is again a spotter for your exam. 44-year-old gentleman, HIV and hepatitis B seropositive. This is a vascular mass, pedunculated, what you see in the upper eyelid, rapidly progressive. What is it? Very good. So it is a Kaposi sarcoma. So what do you do? So earlier we used to excise them, but these are difficult surgeries. They will bleed a lot on table. So with experience, what we have seen is, next slide. So just start them on, many a times you will see they have not been diagnosed as HIV positive. You do a HIV test and then you get to understand the patient is HIV positive. So just send them for a heart therapy. If you improve their immune status, we have seen spontaneous regression, resolution is possible in these cases. Okay, so Kaposi sarcoma, improve the immune status, start the patient on heart therapy, and first look for spontaneous regression. Next slide. So again, this lady, 64-year-old female, you see the typical basal cell carcinoma, multiple, all over her face and neck. So the rolled out pearly margin. So what is this? Next slide. So this is a case of Golin-Gall's cancer predisposition syndrome. It is a rare autosomal dominant disease. It usually happens in young age, but what we need to remember is surgery or radiotherapy has risk of induction from more basal cell carcinoma. So if you send these patients for radiotherapy or excise, you will see new lesions are cropping up from the margins. So these are extremely difficult cases to control. So they have associated developmental defects, odontogenic keratocyst, bone cyst, Palmer plantar pits, Fox cerebri calcification, rib defects. So multi-system evaluation is of extreme importance in this group of patients. So last point I just wanted to touch upon, the targeted therapy. Next slide. So this particular girl walked into my clinic. She was a case of xeroderma pigmentosa. You can see the right eye had a orbital OSSN at the time when she presented to us. Left eye, there was a localized OSSN. So left eye with immunotherapy, it came down. Right eye, we had to enucleate. She's wearing a ocular prosthesis. But what perturbed us was the multiple crops of squamous cell carcinoma which were coming on her face every next month. So initially we had excised few of them. Then we realized that this is just not working. From the margin of excision, new lesions were coming up. So we went ahead and we started this patient on imiquimod. So imiquimod is again a good option. So this is pre and that is post. All the lesions have come down, and this is a good option for such patients, xeroderma pigmentosa patient with multiple squamous cell carcinoma. Also for basal cell carcinoma, this can be used, but this will only work for a superficial case. Wherever it is invasive orbital squamous cell carcinoma, it is absolutely contraindicated. Next slide. So their medical management of eyelid tumors, you need to remember about imiquimod, which is easily available. 5-fluorouracil has also been described. Photodynamic therapy has also been described, which is not available in India now. But what for your exam, something which will come up as recent advance, though not available in India, is vismodegib and sonidegib. They are hedgehog pathway inhibitors. They have role in metastatic basal cell carcinoma, unresectable basal cell carcinoma. But the problem with them is they're expensive and you need to continue them lifelong. Once you stop it, there is a recurrence. So tumor free at 3 months, the rate which is there in literature is 80 to 90%. So just to summarize what we just learned in the last 10 minutes, you need to differentiate benign versus malignant lid tumor. You need to perform in toto excision for benign eyelid tumors and wide excision with margin and margin clearance for malignant tumors. It is best to perform map biopsy in all cases of periocular SGCs to detect pagetoid spread. Chemo reduction helps in performing conservative surgery in extensive sebaceous gland carcinoma. Screen for regional lymph node in all patients, and sentinel lymph node biopsy helps in understanding subclinical lymph node involvement. Protocol based management post excision is important, and we need to know when not to excise. We talked about considering medical therapy for multiple superficial SCC and BCCs. Do not consider radiotherapy for BCC in galls. And targeted therapy is new hope for locally advanced and metastatic BCC. Thank you everyone for patient listening. So any question, please feel free to mail me. I have a flight to catch. Thank you everyone.
Okay, thank you. Now I request Dr. Mishra to give his talk.
I'm Brigadier Dr. Mishra. I'm heading the eye department of Army Hospital R&R, and I'm a vitreoretinal surgeon. So this topic is extremely important, students. This is for you because I've been going to various centers. I'm a regular examiner and a paper setter. So this is indefinitely an examination. You will get a case either in theory or in viva, long questions, short question, but this is the backbone of your examination. So you have to know diabetic retinopathy inside out. So the objective of this lecture is to tell you about the disease burden of diabetic retinopathy, the pathogenesis, the clinical spectrum, management, role of ophthalmologist in early diagnosis, role of ophthalmologist in reducing the risk of developing diabetic retinopathy, and the treatment of diabetic retinopathy. So when do you expect a diabetic retinopathy? Is commonly asked question, what is the diabetic age of a patient? So this is what is the diabetic age of patient, that when do you expect the diabetic retinopathy? So in type 1 is 13% of patients have retinopathy at 5 years, 90% at 10 to 12 years of diabetic detection of diabetes, and eventually 25% of these cases after 15 years develop into a PDR. Whereas in type 2, 40% prevalence after 5 years. After 15 to 19 years, it goes up to 84%. And as far as PDR is concerned, they have a lesser risk. So it's always asked the question. So retinopathy, the PDR incidence is higher in a case of a type 1 diabetes. So up to 25% cases at the end of 25 years. So worldwide prevalence, we know that India has become a diabetic capital of the world. We have around 77 million people with diabetes as on 2019. And we have a prevalence of diabetic retinopathy from 10.25% to 26.15%. We have various studies in India which has taken down this percentage. So how does a diabetic retinopathy pathogenesis? You should know that basic crux in this case is hyperglycemia and oxidative stress. These two are interlinked. So various pathways come into play, which is like polyol pathways, hexamine pathways, AG acclimation, and PKC pathways. They are all interlinked. They will have oxidative stress, which will lead to inflammatory response, and this inflammatory response will cause neovascularization. Lead to increase in the VEGF. Ultimately, it's all connected. VEGF is being increased because of these pathways. And again, VEGF is also adding on to the formation of neovascularization. Ultimately, all these cumulative effect leads to formation of retinopathy. So let us see how does adaptic retinopathy goes and starts in a capillary. This is normal capillary. You can see the you start from inside. It's got endothelial cells which are tightly adherent to each other, forming the blood retinal barrier. They are surrounded by the basal membrane and outside by pericytes. This is a healthy normal capillary. This, we all know, the blood supply of retina, which starts from the inside, goes to the outer side of retina. The blood flow in normal capillary, we all know that in normal persons, the RBCs are very pliant RBCs. They don't get stuck to each other. The platelets are healthy, and there's a blood retinal barrier. So it's all, the flow is very smooth. What happens is, when there is an alteration in the capillary of diabetic retinopathy, you see that the blood, the endothelial cells, the tight junction starts breaking up. It start loosening. The pericytes, there is the thickening of the basal membrane starts happening, and the nucleus of the pericytes starts getting altered. Then, as the damage further progresses, the capillary starts getting thinned out. When it starts getting thinned out, if you see this, it starts bulging. The capillary wall starts bulging, and hence the formation of the microaneurysms and the irmas. This alteration in the tight junctions, which leads to the breakage of the blood retinal barrier and the outpouching of the capillary walls. It starts getting thinned out. It starts getting outpouched. This outpouching, and because of this defect in the RBCs, they become more rigid. The moment they become more rigid, they start getting stuck to each other. The platelets starts getting stuck to each other, and this outpouchings will have the RBCs, which will get stuck inside this, and you will see the thrombosis which is happening. If you see this microaneurysms, it goes into various stages. The stage 1 is the background microaneurysms, which is barely visible even on angiography. Then comes the stage 2, which is slightly more advanced. You can see a dot like fluorescence, a dot in angiography. When it becomes more advanced, it becomes leakage. It starts leaking. So these are the leaking microaneurysms. And when the leakage starts, the edema starts happening. And after the last stage is the thrombosis of these microaneurysms become thrombosed and seals off. This is how I told you that how the formation of clotting, which happens because of the more rigid, non-deformable erythrocytes, which get stuck together, and also because of the platelets, which are drawn there and they become stuck to each other. The shunts, what happens? Normally the shunts are there in the retina, but it doesn't open up. It's a nature's way of increasing the blood supply to the ischemic retina, that these natural shunts which are available between the arterioles and the venules start opening up, and you see these are the irmas. Now, a common question is, how do you differentiate between irma and a neovascularization? So what are the features? Can anybody tell? Because this will be asked when you get a case of a diabetic retinopathy. We'll ask, how do you, because they look similar. If you see clinically, they will look like a neovascularization. So the irma is what? There's larger lumen vessels. They are straighter. Whereas in neovascularization, and irmas are slightly deeper. Whereas the neovascularization, it's more superficial. The vessels are coiled and much finer vessels. And of course, once you do an angiography, the neovascular vessel will be leakage there, whereas irmas don't leak. So this is how it happens. The diabetes, there is a chronic hyperglycemia, which leads to a metabolic response, there's a chronic inflammation, and also there's a microvascular damage, which includes the endothelial damage, capillary occlusion, and leukostasis, which all leads to ischemia. All these are collectively leading to ischemia. Ischemia is leading to increased VEGF. And again, this VEGF is leading to neovascularization and also the breakdown of the blood retinal barrier. So ultimately, all leads to neovascularization and edema. So what are the risk factors of diabetic retinopathy? One is a non-modifiable, which includes age, race, sex, type, puberty, and pregnancy. And modifiable is the diabetic control, hypertensive control, anemia, nephropathy management, weight reduction, and exercise. So what is the common symptom? How does the patient come to you? They usually come to you with diminution of the central vision, and which happens because of the diabetic macular edema, or could be because of the ischemia. And they can also come with a field defect. Field defects come in an advanced stage when you have a traction retinal detachment or a vitreous hemorrhage. So we all know that the diabetic retinopathy can be divided into 3 stages: non-proliferative, proliferative, and advanced eye disease. So this is the non-proliferative, which is further divided to mild, moderate, severe, and very severe. So mild, you can see the microaneurysms with hard exudate. This is when you do an angiography, you can see microaneurysms as hyperfluorescent dots. The moderate one will have more extensive microaneurysms, and you will have hemorrhages with cotton wool spots and venous beadings. So if you see this kind of a picture in the hard exudate in a ring form, which is known as a circinate retinopathy, you will invariably find a leaking microaneurysm, which is cause of this. So the central part will have a leaking microaneurysm, which will have a bearing on your treatment protocol. That means if you just do a focal laser in the leaking microaneurysms, this kind of circinate retinopathies resolve. And moderate is, we all know that extensive microaneurysms, hemorrhages. I have told you about this. Location of diabetic retinopathy. Hemorrhages in diabetic retinopathy, it could be a vitreous hemorrhage. If you start from anterior to posterior, it could be vitreous hemorrhage. It could be pre-retinal hemorrhage. It could be superficial hemorrhages. It could be deep hemorrhages. So these superficial hemorrhages, they happen in the superficial capillary network and deep in the deep capillary network. They are flame-shaped. Superficial is flame-shaped. It's commonly asked why they are flame-shaped, because it takes the shape of the nerve fiber layer, and the deep are in the nuclear layers. The development of cotton wool spots, we all know that it's because of the ischemia in the superficial and deeper capillary network. The venous dilatation, you can see the beading in the venous. So this is also part of the vascular changes in the retinopathy. So this is more of a pictorial to make you understand that how it looks like. So the severe form will have we all know that ETA Darris study said that 4-2-1, rule of 4-2-1. So you have more than 20 intraretinal quadrants, hemorrhages in all 4 quadrants, definitive venous bleeding in 2 or more quadrants, and prominent erymas in 1 or more quadrants. So we all know that retinal edema is very important part of the diabetic retinopathy. All these microaneurysms and erymas, they start leaking, and they thicken the retina, causing the edema part. Then comes the proliferative diabetic retinopathy. So we have any retinal neovascularization, whether it is an NV or NVD, will label into as a proliferative diabetic retinopathy. This is how the new vessel starts forming. And in advanced eye disease, there is a traction retinal detachment or NVG. So NVG and traction retinal detachment makes into an advanced eye disease. NVG starts from the pupillary margin and goes into the angle. There's a contraction of the angle and causes a closed angle glaucoma. So this is the progression of a diabetic retinopathy. Background diabetic retinopathy will have microaneurysms, microhemorrhages, small area of ischemia. When the predominant ischemic element is there, then it goes into from pre-proliferative to proliferative stages. And when there is a predominant edematous component, it goes into a non-proliferative diabetic retinopathy, which could be a cystoid macular edema or a fibrous macular traction with severe vision loss. So how the diabetic macular edema progresses, if you see that there are swelling which starts from, if you see the top, there is no macular edema. But incipient cystoid edema, you will have two levels of edema cells, one the inner and the outer layer, and they start coalescing, they start collecting, they start getting mixed, and they form a large cyst. And once the disease is remaining there for a long time, they collapse and cause a fibrosis. So the classification which I have told you is that apparently no diabetic retinopathy, mild, moderate, severe, and PDR changes. The classification of DME, it's a very important short questions you get. That classification of how do you classify DME. So it could be apparent, that is no apparent DME, mild DME, moderate and severe DME. Mild will have some retinal thickening which is not involving, which is away from the center of the fovea, center of the macula. Moderate is retinal thickening or hard exudates near the center, but not near the center, but not involving the center, and severe is the involving the center. So how do you manage? You have a strict glycemic control, optimization of BP, hemoglobin, lipid profile, reduction of obesity, aerobic exercise, and management of nephropathy. So basically regular screening is very, very important in these cases. When you do not have any diabetic retinopathy, you do it yearly, and once it starts developing, then the reduction in the duration of review reduces. So as far as glycemic control is concerned, we should have a good glycemic. One should not aim for a very strict glycemic control, because patient can go into hypoglycemia. So a good glycemic control, which says around 7 or less. Also, we have seen that rate of progression decreases as the HbA1c is well controlled. Also, as far as the blood pressure is concerned, the various trials like ACCORD study has shown that one should do an adequate BP control, not a very strict, because once you go for a strict control, the risk for other comorbidities increase. Also, the ACCORD study studied about this important study from the eye point of view and from the general medicine point of view. It also studied about the role of lipid lowering agents, phenofibrate, in reduction of the diabetic retinopathy. So, diabetic macular edema, the treatment part remains that the mainstay of treatment in diabetic retinopathy in edema is anti-VEGFs. We all know anti-VEGFs, bevacizumab, ranibizumab, aflibercept, brolucizumab. Brolucizumab is a very important. This recently got a FDA approval in treatment of diabetic retinopathy, and faricimab. Then intravitreal steroids form a very, very important part of treatment in diabetic retinopathy. We have an international paper in that when we compared the role of dexamethasone implant versus triamcinolone in treatment of diabetic retinopathy. So 1 milligram of triamcinolone, preservative-free, very important. You should say that word, preservative-free triamcinolone in treatment of is equally effective in treatment of diabetic macular edema, where the patient is poor and cannot afford fancy treatment. Laser, one cannot understate the importance of laser in cases of diabetic, which could be a grid laser, or it could be a focal laser, which I told you, and a modified grid laser. So this is once the patient, you remember that if the patient is not responding to multiple injection of one anti-VEGF, please switch over the anti-VEGF. Here's a case which he received multiple injections of bevacizumab and ranibizumab, didn't respond. We switched him to Eyedia, and after 2 injections, patient had the edema resolved. So as far as PDR is concerned, how do you treat a PDR? PDR is definitely the main stay of treatment in the case of PDR is anti-VEGF and laser. One very commonly asked question that, in the case of a diabetic retinopathy, if you see a small NV which is in a 2 o'clock quadrant, what do you do? So invariably the student says, we'll do a sector laser. No. In diabetic retinopathy, there is no role of any sector laser. So it is a PRP. In the case of a PDR, it has to be a PRP, nothing less than PRP. So what happens when there is a vitreous hemorrhage? If it is a mild, one can wait for 3 months. Give laser if you can see the retina, augment with anti-VEGF. And if it is dense, if it is not resolving in less than 3 months, one should operate. This is how this is a vitreous hemorrhage, which is you have to do a gentle vitrectomy. And this is a case where there was a PDR with a tractional detachment. One has to do a complete vitrectomy. While doing vitrectomy, one has to be very, very gentle. You cannot do a PVD because this PVD, they are firmly adherent and they tend to bleed a lot. So all these cases, it is commonly asked, what do you do? So you give a preoperative anti-VEGF if the macula is not involved. If the tractional retinal detachment, also you can give anti-VEGF. But you have to operate all these cases within 4 days because after 4 days, the fibrovascular response is there so that they can tear off the retina and increase the TRD. So that's all. Any questions from your side? I'll be happy to. So, but believe me that this is a very, very important topic from theory, from practical point of view. And once you pass out, you will get cases. So you are responsible for all these cases. So you should know everything inside out. Thank you.
To know about the basics of retinopathy of prematurity, so the slides are not coming. Okay. So you need to know the normal retinal vasculature development. So it starts developing from the disc to the periphery by two processes, which is vasculogenesis and angiogenesis. When babies are born, most of them would have a temporal avascular peripheral retina. You see that it usually develops by 39 to 41 weeks. So what happens in utero? The retina matures first ahead of the vasculature. This requires a lot of oxygen. There is an increase in oxygen demand. So there is an increase in the VEGF there. This VEGF actually drives the vessels to grow from posterior to anterior. What happens when the baby is born preterm? The retinal vasculature is not developed and the baby is exposed from an oxygen saturation of 30 to 40 to a saturation of 90 to 99%. So what happens? There is a hyperoxic stage. So these are the phases of ROP. So when there is a hyperoxia, naturally there is a reduction in the VEGF requirement and there is a compensatory vasoconstriction. So, but the retina continues to mature and the requirement for oxygen increases. So at this stage, you see that VEGF is low and there is a vasoconstriction. This leads to a stage of hypoxia. When there is a hypoxia, then again the VEGF level would rise. But as a baby is growing, then you see that the insulin growth factor levels also naturally goes up. So when there is an interplay between these factors, then the vasculature goes into a proliferative stage. So you need to remember these two phases of ROP. There is an initial hyperoxia, there is a next hypoxia level, which leads to the proliferative phase of ROP. So that is the reason why you don't screen the babies immediately after birth. You wait for that proliferative stage to develop to see whether the ROP is coming. So the peak incidence is between 32 to 34 weeks. And as I mentioned, any baby who is born less than 34 weeks, easy to remember, screen every baby at 30 days of birth. And if the gestational age is less than 28, screen the baby at 20 days of birth. And there is already a neonatal forum guidelines for screening in India. All babies who are born less than 34 weeks of gestational age or less than 2,000 grams of birth weight should be screened. And any babies with any other risk factors as per the guidelines should be screened. Why is it important to screen? Because 50% of these babies can develop a sight-threatening retinopathy of prematurity, which if we screen and treat can prevent a lifelong blindness. What are the ways to screen? Ophthalmologists can directly use an indirect ophthalmoscope and screen the babies. Now we have an alternative. You can use a fundus camera imaging like a red cam or a Forus camera and send the images and can do a tele-ROP screening also. And when you go for a screening, you should have all these equipments. Indirect ophthalmoscope, a 28D or a 20D lens. You should have an ROP card to document the findings and to give the babies as a reminder to come back for a checkup, and if needed for a laser, you should have a laser indirect ophthalmoscope and a speculum intender and the topical dilating drops and anesthetic drop. Before going to the examination, you should collect the details regarding the baby, especially the most important birth weight, gestational age, any maternal risk factors if there are there, or any fetal risk factors. Then you have to wrap the baby to prevent any hypothermia. Dilate the baby with the 2.5% phenylephrine. It should not be more than that. And the drops should be put 2 times 15 minutes apart. And you have to put topical anesthesia. And also you can give some sucrose in a gauze to calm down the baby. After putting the topical anesthesia, you have to put a speculum and a depressor. Now, before going to the fundus, you have to see, using a 20D itself, you can look at the anterior segment, look for what is the extent of pupil dilatation. If you see a well-dilated pupil, then you should be happy. If you don't see that, if a non-dilating pupil, always look at the peripupil rim, look for any neovascularization of the iris. Also look for any persistent pupillary membrane, and you should not get confused between these two. Also associated, look for any corneal abnormalities or any vitreous haze and cataract. Now, documenting the fundus is as per the ICROP classification, which came up in 1984 and which evolved with time. And the recent one is ICROP 3, which came out in 2021. All of you should read about this modification. So the ROP should be documented. First, the zone. The zone 1 is with disc as the center, radius, which is double the distance between the disc and the fovea. This is zone 1. Zone 2 is a circle which is drawn tangential to the nasal aura. So if you see a baby with the vascularization complete till aura, then it fits into zone 2. And the peripheral temporal remaining one is the zone 3. And in the recent modification, you can see that the zone 2, the 2 disc diameter away from zone 1 is called zone 2 posterior. This is to document for that. And sometimes you will see that the vessels might have grown till the zone 2, but you see a small term of extension to the zone 1, which is avascular. Then you should document it as zone 1. Even though the rest of the vasculature is in zone 2, it is zone 1 secondary to the notch. So this is a modification which has come in ICROP 3. And now, depending upon the stage 1 is just a demarcation line. If you see a little volume to that, it is stage 2, which is a ridge. If you see that it is lifting to the vitreous, then it is stage 3. And when you have a retinal detachment, and if it is not involving the fovea, it is stage 4A. If it comes to involve the macula, it is stage 4B. And again, when there is a total detachment, it is stage 5. Recent classification have again subdivided stage 5. If you can see the disc, then it is stage 5A. If you cannot see the disc, that means the posterior is closed, then it is stage 5B. Along with this, if you see any abnormalities in the anterior segment, like a corneal opacity or any secondary glaucoma, then it goes to stage 5C. And one very important thing which you should look is plus disease, which, as I mentioned, it is the iris neovascularization. In the posterior pole, look for vessel dilatation like this. So if these are there, then that is the plus disease. And another addition which came up later is aggressive posterior ROP, which means like you don't see that classically described stages over here. You see the loop like a network of vessels all around. You don't see the stage 1 demarcation line or anything. And the reason addition to this is you don't use the word posterior, because this kind earlier it used to be in very low birth babies and it used to be in the posterior zone 1. But now we do see this in bigger babies and even beyond the posterior one. So that now it is called aggressive ROP only, not aggressive posterior ROP. And you might see a hybrid ROP where you see in some area there will be collaterals and some area there will be stage disease. This is called a hybrid ROP. Now coming to management. So there is type 1 and type 2. Whenever you see a type 1 ROP, what is type 1 ROP? In any zone 1 or zone 2, if you see any plus, that is treat and type 1. And in addition, if in zone 1, if you see stage 3, without any plus, again that is type 1. So any plus, treat, type 1. Other than that, zone 1, stage 3, no plus, treat. So easy to remember. Rest all babies you need to follow. Coming to treatment. So the culprit is avascular retina and we told it is a VEGF. So you need to tackle these two. So the earliest one was cryo ROP. Cryo, they told, treat the baby when the disease reached threshold, and it led to anatomical outcome. Then came ETROP. Don't wait till threshold. Treat early. That is early treatment. Treat with what? Laser. And it led to both anatomical and visual outcome. Now, this is still the gold standard treatment, that is laser treatment. So as I mentioned, treat type 1 ROP with laser. Now, which laser to use? Diode is the preferred one. Why? Because 532, in case the baby has a neovascularization of iris or a persistent pupillary membrane, the wavelength absorbs hemoglobin at that level and it might cause some anterior segment ischemia or iris sector. But if you don't have, still you can use a 532 laser. So both the lasers can be used. Now, the burns should be confluent, starting from the edge of the posterior to the ora serrata, and it should be confluent burns. If there is a non-regression, there is an option to treat even posterior to the ridge also. So it should be confluent burns. Now we have cryo, laser, and we need anti-VEGF. Why? Because laser and cryo will take some time for it to act, and now we do have more and more posterior disease. When you ablate, you get more of field loss. So you want to preserve posterior retina as much as possible, and VEGF acts faster. So that is why we use anti-VEGF. So in which cases? Don't use in type 2, don't use in zone 2, it is in zone 1, APROP or a half zone ROP. And which are the anti-VEGF? Bevacizumab, ranibizumab. And the only FDA approved drug is aflibercept as of now. So this is the difference. So anti-VEGF, it is easy to administer and it acts rapidly, but you need to have a longer follow-up for these babies because recurrence can happen higher in this anti-VEGF group. Laser, it takes longer time. So this is a safer ROP which you need to know about it, the protocol for giving anti-VEGF injection. You can go through that. So what do you look after treating these babies? Look for regression. What? Reduction in the plus, reduced vascular dilatation, involution, and better pupillary dilatation. So after treatment, if you see the next day the pupil is really dilating well, then it is good. So this is what you should look. And this is another modification which have come in the regression pattern with what it has regressed. Okay, whether it is complete or incomplete. And with more and more of use of anti-VEGF, you see more and more babies following up with extensive peripheral avascular retina. And again, reactivation, you have to mention to what stage the baby has been reactivated, whether it is stage 2 or stage 3. And when to stop? When the retina is completely vascularized or the ROP has regressed, and you need to follow up these babies on a regular basis. So with laser, you need to see the baby at 1 week, 2 weeks, and then 12 weeks, and then follow up 6 months. With anti-VEGF, you need to see the baby after 24 to 48 hours, and you need a longer follow-up with anti-VEGF. And don't give the baby anti-VEGF when the baby has reached almost like 39-40 weeks, or if you have already seen that there is a fibrovascular proliferation, because it can lead to a complication which is called crunch ROP. And you should document if any late complications like late retinal detachment, peripheral avascular retina, any of these things. Always remember, because as you now understood the pathology, that there is a time period or a window period for this disease. So you need to catch the babies on time. And this is at least and if you treat the babies on time, 85% of the babies, the vision would be saved. And this is the guidelines. You should read, everybody should read this article by Shukla. Okay, thank you.
Last day, last session, last talk, I really appreciate those of you who are sitting, and I assure you I will not exceed the time limit. In fact, I'll finish it in 5 to 7 minutes. So the topic is strabismus. Again, not a very interesting topic, but it's an important topic, and the talk has been prepared keeping the postgraduates in mind. For successful strabismus management, you must remember that most of the battle is outside the operating room, even if it's a surgical case. Deciding the surgical plan, the timing, and a basic knowledge about the anatomy and the physiology of the extraocular muscles and how they act go a long way in ensuring surgical success. So I'll just touch on the salient features which you need to remember when you are planning strabismus surgery. See, I'm sure all of you know what incomitance is. Incomitance is when the angle of deviation changes in different directions of gaze. So this is what a comitant squint looks like. the deviation is remaining the same whether the patient is looking down, looking straight, or looking up. Now, this is an obvious incompetence where the patient has a left lateral rectus palsy and the eye is just not moving towards the left. Again, this is a significant incompetence where the left eye is not going up. This is a patient of restrictive strabismus. And in certain patients, the incompetence may be subtle. These are the types which you do not need to miss. This is a kind of a V pattern exotropia, where the deviation is lesser in the down gaze here, and it is increasing significantly in the up gaze. So these patients you need to be careful about, and you should not miss them, and account for their incompetence when you are planning strabismus surgery. Now, this is the classification, a simplified version of the classification which all postgraduates should know. It is important to know that exotropia is not reverse of esotropia. It is a totally different pathophysiology. The variants in red are the common types, and the variants in black are the not so commonly seen types. The acute onset esotropia is having a kind of an epidemic in the post-COVID era where there has been an excessive use of mobile phones. Now, the point to be remembered here that certain types of strabismus do well just with a good cycloplegic refraction and prescription of good glasses. So, cycloplegic refraction, retina examination, appropriate glasses, and amblyopia management is the initial step in all patients of strabismus. Now, the clinical features, I'll not go into the detail, but just remember that esotropia requires early surgery because the real risk for amblyopia, and surgery may be delayed in exotropia, specifically if the patient or the child is controlling the deviation at certain times. Now, botulinum is an alternative to surgery and should be offered as an alternative when measurements are unreliable or the child is unfit for surgery. But surgery, once indicated, should not be delayed. It should be taken up as early as possible. Now, these are the sensory goals. We aim to restore binocular single vision in primary position and in down gaze. That is the acceptable outcome, and restoring it in all direction of gaze is the ideal outcome. When this is not achievable, we at least expect a motor satisfaction wherein an orthotropia or a small amount of microtropia is desirable for esotropia, and a small consecutive esotropia is desirable in exotropia. Now, the residents often get confused, just 2 more slides after this and a small video. So residents often get confused about which muscle to operate, which eye to operate, and how much to operate. So this I've tried to answer in this slide. It has been simplified from large number of pages of von Uden. See, resection surgery is by far the commonly done surgery for both esotropia as well as exotropia. In small children, esotropia, maybe bimedial recession may be considered, but it is always easier to convince the parents to operate single eye. They always want one eye surgery. So R&R surgery is acceptable for all types of strabismus. Now, which eye should you operate? You should operate the eye with better vision if the post-operative binocularity is achievable. Agar patient is controlling the deviation, it's a young patient, recent onset strabismus, then we operate on the eye with good vision. We operate on the eye with poor vision where there is no chance of achieving binocularity post-operatively. A long-standing deviation, a sensory deviation, a constant deviation in an elderly patient, you operate the eye with worse vision. How much surgery should be done? This has been simplified in this nomogram, wherein you must remember that recession surgery on the medial rectus is more effective and resection surgery on the lateral rectus is more effective. You can expect to get 5 to 4 prism diopters of correction for each mm of medial rectus recession. So if you are attempting to correct a 20 prism diopter of esotropia, then you can do just 4 to 5 mm of medial rectus recession and the patient would be corrected. If it's a larger angle deviation, you will need to divide the dosage between the two muscles that you are operating. Now, all the speakers have shown their videos. I am showing here a video, a surgery done by my fellow. As a beginner, remember that use a paralimbal incision and take these marking sutures. On the conjunctiva, they help in good approximation. Take traction sutures to rotate the globe in the preferred direction of gaze, and once you have exposed the muscle, expose the area, use two muscle hooks to identify this is the medial rectus which has been identified. You hook it, make sure that you have the whole muscle. You will cauterize the insertion and take 2 bites to secure the edges of the muscle. Then you disinsert the muscle and mark the area where you want to recess it, and then you secure the muscle carefully and cut out the adhesions. While taking these bites, you must remember not to go too deep into the sclera. Just so, like most of you have been repairing cornea, where you are told that you must take a 90% thickness bite. In sclera, even a 1/3 thickness bite is sufficient, and it offers enough strength for the muscle to be held. Don't go too deep, especially in children where the sclera is thin. Now, I continue with the video. You remove these adhesions and then you get the conjunctiva back by either the vicryl ato suture or tissue glue. Now, this is the other side muscle which is being resected. Now, you take the muscle on 2 muscle hooks, and both the insertion and the point where you want to put the sutures after resection, they will be cauterized, and the muscle will again be secured with 2 6/0 vicryl sutures. Right? The stump will be disinserted and the muscle will be pulled back to the insertion, and the conjunctiva would be closed again with atovicryl or with nylon sutures. Now this is the final conclusion. You have to select comitant deviations for your initial surgeries, and intermittent exotropias have better outcomes. So for beginners, IXT is the patient of choice. Preoperative use of brimonidine eye drops causes vasoconstriction. Remember to connect the cardiac monitor for the oculocardiac reflex. Paralimbal incisions are the best. Don't try fornix incisions initially. Take conjunctival marking sutures. Dissect under direct visualization and ensure good hemostasis. And be careful when you are taking muscle and scleral bites. And a neat conjunctival closure is important because many of these children are going in for a cosmetic procedure. And thank you so much for a patient hearing. This is my email ID. You can contact me for any queries, and I would be happy to answer them. And these are my textbooks. You can refer to them. They are available free of cost and on the Telegram. Telegram is the site where they are available. Right. Thank you.